and fostering a community where all individuals can flourish. My name is Ariana Contarino, and I am the current president for Phi Alpha Omicron Epsilon Chapter at USC. Joining us today from our board of scholars, we have Nydia Sanguino, our research liaison and symposium coordinator, Devin Hernandez, our DSW VAC representative, Jerry Cheney, our recruitment chair, Yvette Hurtado, our MSW VAC representative, and Giselle Cano, our social chair.
Hello, everybody. I would like to introduce myself. My name is Nydia Sanguino. I am the research symposium liaison with Phi Alpha Honor Society, and I would like to welcome everybody and thank everybody for their time, their patience, and for all the hard work you guys have done to make this happen.
Good morning, everyone. My name is Devin Hernandez, he, him. As mentioned, I am the VAC Doctor of Social Work representative. I'm doing my Doctor of Social Work at the University of Southern California, finishing my first year. Pleasure to have you all with us today.
Good morning, everyone. My name is Jerry Cheney. I'm the recruitment chair for Phi Alpha here at University of Southern California. I'm an MSW student, and like everyone else has said, a pleasure to have you here and excited to see all the research that's being done.
Good morning, everyone. My name is Giselle Cano. I'm a MSW candidate and social chair for Phi Alpha. Thank you so much for joining us this morning.
Good morning, everyone. My name is Yvette Hurtado, and I am the MSW representative here for Phi Alpha. I'm in my last year of my MSW at USC, and I am very excited to hear everyone's research.
It seems I have mixed up two slides, but our agenda today is as follows. We began with our opening statements, and now we'll continue with our presenters. At about 10:15, we will have a 10-minute break. And it is a little bit time constricted, so please try to stick to your time. We will try our hardest to give you little notices when your time is coming, okay?
All right, I have the pleasure of introducing our first two presenters. Kat Calabro is in their final semester of the Master of Social Work program at Gallaudet University. They currently serve as the president of the Mu Pi chapter of Phi Alpha Honor Society at Gallaudet. Professionally, they work at a nonprofit in New Jersey that supports individuals with disabilities and also serve as an ABA therapist for children on the autism spectrum. Their research interests focus on the intersections of LGBTQIA+ identity, deaf and/or hard of hearing experiences, and mental health. As a future social worker who can communicate in American Sign Language, also known as ASL, and is knowledgeable of deaf culture, they are committed to providing accessible and culturally competent mental health services. This semester and beyond graduation, they will be conducting a research study on the mental health experiences of the LGBTQIA+ community, furthering their commitments to advocacy and inclusive mental health care. Joining Kat is Brittany Stuckert, and they are a graduate student at the MSW program, also at Gallaudet University. They are the secretary for Mu Pi chapter of Gallaudet University. Currently, they are interning as accommodation coordinator at the same institution in which they go to school. Their internship serves students with disabilities by providing academic accommodations to ensure that they succeed in their academic years without barriers. Their interests would be mainly focused on mental health in the deaf and/or deaf-blind, as well as hard of hearing population, to spread the awareness and increase the resources for supports that they may need for their mental health in the college setting. Welcome.
Okay, you can now share your screen.
I'm on my brother's computer.
Sorry, can you repeat that?
Yeah, sorry, I'm on my brother's computer, so it's just taking me a second.
Oh, no worries.
I'm having a little bit of technical difficulties. Nadia, I know you have my presentation. Would you be
I
able
have
to
it.
share your screen? Thank you so much. I
Absolutely.
really appreciate that.
No worries. Let me just open it up. Okay, give me 1 second.
While Nadia is doing that, I just want to thank everyone for having me here. Also, as you see, I am voicing. I am hearing. I am a graduate student at Gallaudet University, which is the only bilingual deaf and English university in the world for ASL and English. So I do have the ASL interpreter here. She will be interpreting my English presentation. My classmate Brittany was unable to join us today due to a medical emergency. So I apologize for that, but we still have our interpreter, our wonderful interpreter here for us. Okay, so my presentation is, oh no, you're good. I also have my notes.
Okay. Okay.
Accessible mental health services for the deaf and hard of hearing community, and I am Kat Calabro. And I am that's fine, you can keep it there. My pronouns are she, her, and I am the president of Gallaudet's chapter of Phi Alpha Mu Pi. All right, so did you know that that mental health conditions such as depression, anxiety, substance use, psychosis, all of those mental health conditions are more prevalent in the deaf and hard of hearing community compared to the general hearing population? And those numbers are actually 33.8% of deaf and hard of hearing individuals struggle with these conditions compared to only 6.8% of hearing individuals. Go ahead to the next slide. Thank you. Now, why does this happen? So this happens for a few different reasons. So there is a lack of mental health services in ASL. That could be ASL clinicians, social workers, psychiatrists, psychologists, or just a general lack of ASL interpreters available for these appointments, these meetings, these sessions. There's also misinterpretation of symptoms due to cultural differences. So providers might not always get the full picture and they miss information, which leads to misdiagnoses. There's also a lack of support. A lack of support professionals competent in not even ASL, the language itself, but deaf culture, because it's not even just a different language. It's its own culture as well. Along with, many of us know that there is stigma, discrimination, and oppression that happens in the hearing community, but also within the deaf community, even more so. There are differences in body language between hearing and deaf communities, such as facial expressions, hand movements, and just like body movements, communication styles. Also, there's a higher misdiagnosis of psychosis in the deaf community, and that's because providers see the body language, facial expressions, and way of communication from a deaf person and think that that is psychosis. So the behaviors that a deaf person is presenting, that is just part of deaf culture, a hearing professional who is not aware of deaf culture misinterprets that. Okay, next slide. Now, this lack of support in ASL and in deaf culture by medical professionals and like social work professionals has real world consequences. So there's a higher rate of untreated mental illness. There is an increased use of substance use and suicide attempts. the unemployment rates are incredibly high. There are barriers to education, and this also includes social isolation. There was a study done in 2017 where adults aged 25 to 64, 53.3% of deaf individuals were unemployed compared to 75.8% of hearing individuals. Or no, I'm sorry, I swapped that. So 75.8% of deaf individuals were unemployed, which is a 22.5% employment gap
Thank
between
you.
hearing and deaf community. Next slide. How do we fix this? How do we improve the accessibility of mental health services for the deaf and hard of hearing community? So there is the deaf-centered approach, which is taking someone's deafness and using that to their advantage, focusing on their strengths. We want to encourage more mental health professionals to educate themselves on deaf culture, educate themselves on ASL, also making interpreters more accessible. There is an ASL interpreter shortage, which means that it's difficult to get access to an ASL interpreter for important appointments, meetings. Additionally, social work students, we often learn about different disabilities, autism, Down syndrome, learning disabilities, but we don't often learn about deafness and deaf culture and what it's like to work with someone who is deaf. Now, go on to the next slide. Now, I can talk about this for hours, but I know I don't have much time. So that concludes my presentation, but please, if you have any questions, I would be happy to answer any. And then on the next slide is my references.
So now we open it up to the floor. If anybody has questions, if anybody has a comment. I want to say thank you, Kat. I mean, I don't think that you're right, in the 2 years that I've been in school for my master's, I have not talked much about the deaf community. I have attended church that is specifically for deaf community. I went to mass once, which was really interesting. I had never participated in that. And it was just amazing to see how people communicate within church itself. Because I always go to, where everybody just listens. So it was really intriguing. And I appreciate you bringing this to our attention. I have a couple questions. Dr. Yamada?
Good morning. Thank you. I enjoyed that.
Thank you.
I was really curious. Do you have any recommendations on how to use AI or other resources available to help students who are deaf maybe feel more integrated socially while they're in their MSW program?
Yes. So there are many different ways to utilize technology for clients, for students, for friends, family. There are things such as VP, talk to text. So VP is video phone. I actually am a part of a company, Hudson Community Enterprises. That's a nonprofit I work for. And we have a deaf and hard of hearing program. So if you would like, I'm sure I can get your email from Nadia. I would love to share some of those resources with you and whoever else wants after the event today.
Thank you. I can make them
course, thank you.
available on our school website.
Yeah, definitely. I will definitely share. Thank you.
Hello, Kat. I just want to make a comment. Is that okay? You are on mute.
Of course, of course.
Okay, thank you. My name is Dr. Ugo. Thank you so much for presenting. I work with a school district. I'm here in Minnesota. I work with a school district, and they have a population of deaf and hard hearing, including speech, students in classrooms.
Mhm.
You are right, because culturally appropriate staff are not given to them or not provided for them. This population of children, in some cases, they misdiagnose them. You know, so yeah, you are right by saying that. In some cases, they misdiagnose them, or, you know, yeah, or they don't know what is going on. However, they do not make referral, you know, because I'm part of this team as a multidisciplinary team. And when you are providing services, you don't know what is wrong, and you don't make referral to those who can culturally provide appropriate services to that student, you are not doing them a justice, you know, you are doing them this service. So thank you so much for providing this summary of your dissertation.
Thank you. Thank you for sharing. I appreciate it.
You're welcome.
Thank you so much. Hi, Samantha, you have your hand up.
I do. Thank you so much for the presentation, Kat. I was just curious if you had any recommendations on how we as hearing students who want to help the deaf community, you know, just how we can help them in these ways with their journey, with their mental health, and even just in general as students, adults.
Yeah, so that's a great question. I have through my education with disabilities, with deaf culture, I have started to stray away from the word of helping deaf people and just helping people in general. And I started reframing my language to I support people with disabilities. I support deaf people because deaf people, they don't need my help. They can do anything, they can do everything. So, can I support them? Yes. So, ways that I can support deaf people and people with disabilities in general, I can educate myself. I can use my privilege and advocate for them. I can educate others. I can become more culturally competent on deaf culture, other disabilities, other cultures in general, because I mean, there's so much that I don't know and I'm learning every day. A way to educate yourself on deaf culture, honestly, TikTok is great, YouTube. Take an ASL class. There's so many free ASL education resources out there. And if I can if you take anything away from my presentation, if you want to learn ASL, learn from a deaf person. Do not take a class from a hearing person. You want to learn from someone and it is their native language. I strongly suggest learning ASL from a deaf person. That's the best way to the best way to learn.
Thank you so
Thank you for your
much.
question. Thank you. Thank you, Samantha.
Okay, if there are no more questions, we're moving on to our second presenter.
I got a different slide than the one that you pulled up. So I'm not sure. The slide I got shows that I was in the second presenter, which was the email.
I sent a secondary, I sent one this morning because there were a few changes I had to make. I'm so sorry.
Oh, okay.
Is that okay?
Yeah, sure. No
Yes.
problem.
Just the second person has another little event to go to. So if that's
Yeah,
okay, I
no
will.
problem.
Okay.
Okay, I'll go ahead and introduce our next presenter. It's going to be Olga Komandouris. Olga is a third-year PhD student at USC Susan Dworak-Peck School of Social Work, researching topics affecting youth experiencing homelessness. Her research focuses on ways housing instability intersects with violence, involvement, and exposure, particularly gun violence among youth. Komandouris is particularly interested in ways positive relationships with adults can mitigate unhoused youth PTSD symptoms. She's excited by deep bidirectional collaborations with youth, community, and service providers to guide practical applications in program development, serving unhoused transitional age adults and youth well-being. Other research interests include adding evidence to community-based practices for violence prevention, for policy change, participatory action research models, survivor-centered voice, trauma-informed research, community-engaged arts-based healing modalities, housing equity, and guaranteed basic income program.
Thank you so much for that introduction. I'm going to share my presentation now. And let's see if we can. And now let me get it presenter view. Let's see. Up. Oh, slideshow. Presenter view. Okay, there we go. Are you seeing just the slide or are you seeing my notes and the slide?
We're seeing presenter view as well.
Oh, okay. Oh my. All right. Let's see.
I wonder, Nydia, would it be okay if you show your screen again, Nydia, and then that way Olga can do her notes in the background? Is that easier?
Yeah, I would like that actually. Thank you. I'm
Nydia, can you
sorry,
do that?
Awesome. Okay.
Okay, can everybody see it?
Yep.
Perfect. Okay, you can start, Olga, and you just let me know when you need me to move.
Thank you so much. I really appreciate this. I was kind of attached to my notes at this point. Okay, so hi everybody. My name is Olga Komandouris and I'm a third year PhD student at USC. My work focuses on youth experiencing homelessness, and this particular paper talks about its intersection of their experience with community violence. My dissertation area is understanding how positive adult relationships can mitigate their PTSD symptoms. So there are over 4.2 million youth and young adults experiencing homelessness in the US in a year. And there's been a significant rise in youth homelessness in the United States in the last year, according to HUD. So according to HUD's 2024 Annual Homelessness Assessment Report, there was nearly 150,000 youth under 18 experiencing homelessness on a single night in 2024. This reflected a 33% increase from the previous year. Additionally, unaccompanied youth homelessness rose by 10% in 2024, following a 15% increase in 2023. These are alarming trends nationwide and suggest surpassing the past count of 4.2 million. Without regular shelter, youth and young adults experiencing homelessness are vulnerable to multiple and oftentimes co-occurring adverse health outcomes. When unstably housed, they're likely to experience violent victimization, which may have negative impacts on their mental health conditions, including suicide risks. Youth or young adults are constantly worrying about where to sleep, where to get their next meal. This generates chronic states of stress and anxiety, leading unhoused youth to likely engage in risky behaviors. For example, survival or transactional sex, panhandling, substance use, or drug sales, all of which can further exacerbate their exposure to violence. Considering all these trauma exposures, it's not surprising that more time youth are unhoused, the more harms of all kinds they experience. Research shows that youth with minoritized identities, in particular Black and Hispanic youth, Indigenous youth, and sexual and gender minority youth, are disproportionately represented among the population of youth experiencing homelessness in the U.S. Youth are subject to higher levels of everyday discrimination as well compared to individuals who are housed. And while we know that youth experiencing homelessness with minoritized identities experience added sources of discrimination, what we know less about is how, in particular, youth who experience homelessness experience this harassment in their informal and unstructured everyday lives. Okay, next slide. So this particular study that I'm sharing, this paper.
Olga, am I on the right slide? I'm so sorry.
I'm not sure what you're looking at. Is it the one with the signs that say
It says
police?
50% of reported experiences.
If you
It
could
keeps
go to
moving.
the previous one, that would be great.
This one?
Back
Discrimination from police.
again. It says research questions.
Okay.
So
It's because my computer keeps moving and I don't know how it's doing that, but it keeps going on.
oh, I'm sorry. I might have sent you something on a timer. But if you
Oh, no
back
wonder. I was like, what's going on? It keeps moving. Okay,
I didn't even
got
think
you.
about that. So this study boiled down our interest to the following two research questions. How many youth experienced discrimination in public space, and which youth reported more discrimination and harassment? And then discrimination and harassment was looked at particularly by police, by local businesses, and by community. Okay, now the third slide, which shows study characteristics of youth experiencing homelessness. So in our study, we had a total of 220 youth that we measured. This took place in Los Angeles. Okay, so let's see. Okay, so race and ethnicity included measuring Black, mixed race, Latino, and other people of color. In total, we had 83% of total youth of color. So it was a high representation of youth of color. Gender included youth self-identifying as female, male, and gender non-conforming. We grouped together gender non-conforming with non-binary and transgender youth. We collected self-reports of sexual and gender minority statuses. Time homelessness was assessed by asking youth, how long have you been homeless or unstably housed in your whole lifetime? And knowing their exposure to discrimination and harassment was heightened by living unsheltered, youth were counted as unsheltered based on their answers, reporting the location where they had slept the most in the past 2 weeks, which included couch surfing, staying in emergency shelter, or being unsheltered. The design of this study was cross-sectional. We did purposive sampling as part of a longitudinal study of peer-led social network intervention, and it was pursuing HIV prevention among youth experiencing homelessness. The location was in Los Angeles County between 2016 and 2018. This study is all before COVID, and my current research is all using data that's current, actually, this year and last year. But this study is dated before COVID, I'll be honest with you. Okay, eligibility criteria was 18 to 25 and had experienced homelessness in the past 12 months. We surveyed in 3 different drop-in centers in LA, and it was computer-assisted self-administered surveys. The analysis was conducted with negative binomial regression because we found outcomes were over-dispersed in this count data. This cross-sectional study, the name of the study was called Have You Heard? Survey questions were modified from the Williams Everyday Discrimination Scale to address discrimination from police, local businesses which youth experiencing homelessness are dependent on to get their supplies, and from community. They were asked questions like, I am treated with less courtesy than other people. I am treated with less respect than other people. I receive poor services than other people. Police officers or community or small businesses act as if they think I'm not smart. They act as if they're afraid of me. They act as if they're better than me. They were not listening to what I was saying, or none of the above. And our findings determined that 50% of youth experiencing homelessness, let me go back on this. Forgive me, I'm also cycling with that timer thing. Okay, so findings. 75% of youth experiencing homelessness reported everyday discrimination and harassment from the police. We know this is a social justice issue. We know, and research has well shown, that discrimination and harassment from police can cause physical health problems among youth, exacerbate pre-existing mental health symptoms, and create barriers to accessing basic needs. So 75% reported discrimination and 28% reported 2 or more incidences of harassment or discrimination. Among local businesses, 50% of youth experiencing homelessness showed that they had experiences of everyday harassment and discrimination from local shopkeepers. And 15% said they had more than 2 or more sources of discrimination from local businesses. And finally, we have 52% of participants reported discrimination and harassment experiences from their communities, with 15% of youth experiencing homelessness saying 2 or more sources of discrimination from their communities. Unhoused youth with sexual minority identities showed increased rates of harassment and discrimination from police, local businesses, and their community. All 3 sectors had the highest rate of discrimination. Unsheltered youth also reported higher rates of police harassment and discrimination than sheltered youth. And we also found that youth identifying as mixed race experienced more discrimination and harassment by their community members than white youth. So this study suggests that harassment and discrimination is a pervasive and common experience in the lives of young people while they move about public space when homeless. And this high prevalence is corroborated by recent research findings of adults experiencing homelessness in Los Angeles County, particularly the PATH study by Padua in 2024. So to our knowledge, this is the first study to report on these 3 foci of discrimination and harassment of youth experiencing homelessness in LA. And studies have reported numerous mental health toll. It's important to remember that in this sample, 83% were youth of color, because this is an intersectional dynamic. Although we didn't find significance based on race, except for the mixed race, we believe that the statistical significance across race and ethnicity wasn't captured because this wasn't a statistical intersectional study. Secondly, our study found that youth who've experienced homelessness for longer amounts of time in their lives report more discrimination and harassment from all domains. And literature has widely documented the prevalence of structural racism and poverty and how it informs homelessness in the first place. We acknowledge that previous research among Black housed young adults indicates that they report higher amounts of discrimination and harassment by police and mental health impact. And other studies more broadly show positive findings of mental health impact from just the anticipation of racial profiling. We want to know why and how this impacts specifically youth experiencing homelessness, as well as the LGBTQ and sexual minority experiencing youth. And then finally, what do we have? We believe that that we haven't fully discovered all the ways that homophobia and structural racism impacts youth who are experiencing homelessness. And we do have a commitment to trying to understand a bit more about this. So particularly in LA, where we know that policing has escalated in recent years of the homelessness population. Okay, and here are my citations. And that's about it. And sorry for the disorganization of this. And I welcome any questions people have.
Thank you, Olga. It was very fascinating. I know, unfortunately, there's been a lot of movement in our state in regards to certain policies that potentially could forcibly remove and impact those who are impacted by homelessness and or on the streets. Have you and your team kind of thought about what are those implications? Because to my knowledge, I think we just recently had some shifts going on in Los Angeles that have drastically impacted those who, you know, are impacted by homelessness and or housing insecurity.
I think the Padua study that I mentioned was in response to the Grants Pass Supreme Court ruling, but we also have oh gosh, forgive me, I've forgotten the exact number. I think it's like 14-81. There's a law that makes it legal to incarcerate encampments that are located near schools and post offices and all that stuff, which is, even during the fires that we had recently, was making legal sweeps and incarceration of homeless encampments. It was like, it's bananas. So we're trying to keep that awareness. That's what propels us. But yeah.
Dr. Yamada?
Thank you. That was really interesting. My question is, do you have any thoughts on what research social workers could be doing to assist and actually make a difference in this area of homelessness, based on what your findings are right now?
I think there needs to be an awareness around the intersection of youth, essentially looking at gang intervention policies. The interaction between community violence and youth homelessness, there's a bit of an overlap. And unfortunately, this is what social workers, if they can be, obviously, the homelessness workforce is very taxed. They're exhausted. However, and I would add an awareness of working with anti-recidivism, and gang interventionists, community-based violence interventionists is something the homelessness sector needs to be mindful of, and then they can intervene. Unfortunately, the homelessness sector is not quite trained in that. And I would add, the violence interventionists are not thinking about homelessness and unstably housed, the role of that either. The two groups are just not talking. So that's what I would suggest, that social work, these practitioners can just be mindful of the social justice agendas. Like, you know, homelessness sector can work with the Youth Justice Coalition. The Youth Justice Coalition could learn a little bit about homelessness and unstably housed and those politics. So that's, I think, a good first start.
Thank you.
Thank you for sharing, Olga. It makes me think of Homeboys Industries and how they have been able to bridge gaps, and how this model that Father Greg Boyle is able to connect with the youth, have that model for gang intervention, and then help with the recovery, right? Like, it's a process. They need work. They need, right, to be able to maintain themselves and stay out of the street, like you said. So I think that if we could learn a little bit from that model, it would be great, because it would help with that connection. Hi, Yvette, you have a question?
Yeah, I just wanted to add into that. I really love your presentation. Just because I also do work with a lot of youth who have been discriminated, um, impacted, just as impacted. And I don't know if you guys heard of the Department of Health Services. I do work closely with them, and we have strategized like a plan to support youth when it comes to homelessness and harm reduction, and those who have been using like active substance use, or who are trying to get out of the gang. So we do provide services where we house them out of that certain location where we're residing, and we provide them with a temporary shelter. And the shelter base that we do have available are more like house space, just because we do want to create a safe environment and a welcoming environment for these youth who are very vulnerable. And I just want to let you know that I really enjoy hearing to your presentation. It really stood out to me, and it was very well structured. Thank you.
Thank you so much. Yvette, if you could just jot down the name of that agency. I probably know about it, but I sometimes to see it written would be helpful. Thank you.
Yeah, I can drop it down.
Does anybody else have a comment or a question? Okay, then we will move on to our next presenter. Our next let me bring up our slides.
I have the pleasure of introducing our next presenter, Dr. Hudson, who lives in Sacramento, California, currently has a bachelor's in psychology from CSU Sacramento, as well as a master's in social work from Our Lady of the Lake University in San Antonio, and a doctorate in social work from Capella University. They have been working in the field of social work for over 7 years in various fields of foster family agencies, medical social work, outpatient social work, and hospice. For many years working as a social worker, their dedication, empathy, advocacy, and experiences have inspired them to continue to help individuals in need. Social work has not only been a career goal, but has allowed them to continue to use their voice and advocate for others who are unable to speak for themselves. They have a daughter who is 21 years of age and is following in their same footsteps and becoming a social worker as well. Their daughter is expected to graduate May of 2025. And she, along with thousands of others of new graduates of social work, will hopefully lead in continuing the fight of the systematic issues in the United States. Thank you and welcome.
Thank you. I appreciate you. I was just wondering, Nydia, do you mind sharing my presentation? Thank you.
Absolutely.
Thank you very much. So my presentation consists of medical social work barriers in discharging homeless patients from the emergency department. I selected this because I have been in the field of medical social work for many years, and realized the barriers of us providing resources to what we call frequent flyers, many patients that are constantly coming into the emergency room trying to obtain resources that they need in their community. Many of these individuals lack a lot of the barriers because they don't have a primary care, and they use the emergency doctors as their source of resources, as well as the social workers and nurses to help provide that emergency care for them going forward. Next slide. So my main topics of discussion would just be the abstract introduction, and I'll continue with that. So like I had mentioned before, there's quite a few challenges that us medical social workers are facing, assisting these homeless population in the community. And many times what I have found is if you're living in a certain county versus another county, there's only those resources that you can provide to those patients in need. For instance, if I'm living in San Francisco and a patient comes in from San Francisco County and looking for resources in a different county, such as Alameda County or Sacramento, many of those resources I'm not able to provide to them because what they consider us taking away resources that can help provide to another patient in need in that community. So the issues that have affected patient care also have played in a role in our practice, of course. And this capstone research that I collected, the data helped address these barriers of discharging these homeless patients from the emergency department. I used the quantitative generic action research study, which targeted the community-based resident assistants who were pretty much in a local nonprofit agency of the homeless, helping the homeless population, like a shelter, for instance. And then I also used us medical social worker and management level social workers to help gain other resources that we can help collaborate together. And I can give you an example of this. If I'm coming from my background of foster family agencies and medical social work, another social worker could have background in substance abuse, domestic violence. If we all can kind of put our heads together to help navigate some of those challenges and issues, that we can help provide additional resources in the communities for these patients, I feel that we can help decrease the need of these individuals needing a lot of resources in the community. Also, there are community-based social workers that can help assist homeless patients. However, I do feel that the lack of that is many homeless patients do not have cell phones, don't have emails. So it's really hard for the community-based social workers to help navigate and contact these or connect with these individuals in the community. A lot of times we use a system to where we can help use certain resources to where we can say, well, this patient had entered into the emergency department. Are you able to connect with them on the outside? But a lot of times we're identifying these individuals by their clothing because they don't have any way that you can connect to them. They don't have any families, any friends. And so these social workers in the community are really going around in the area trying to help find these individuals in need. Next slide. And I will try to move along. So I kind of discussed this a little bit already, but the social workers utilize the clinical knowledge, of course, and our skills to help identify the community resources and support to access these needs in the emergency department. What I have found in working in 2 different hospitals currently is that us inpatient social workers, we are already overworked, I should say. So it's really hard for us inpatient social workers to help find the resources that we can help provide to the patients in need. We really need to partnership with the community organizations or have in services within a hospital that kind of help navigate and bring that awareness to us individuals in the hospital for inpatient or outpatient to help to address these patients who are coming in and out of the emergency department. Next slide. So I use system theory, of course, which address a lot of the, for us clinical practitioners, the, I should say the challenges and hardships that many individuals have faced. And that's, of course, with their human behavior, relationship, socialization, social economic class and status, and their environment. That helped really navigate a lot of the concerning factors that we see that these individuals are needing nowadays, and that's consisting of substance abuse resources, shelters, domestic violence. Sometimes they're needing Medi-Cal or Medicaid information. So trying to help navigate what the biopsychosocial issue is from these individuals in completing an assessment really helps, so we can help navigate what exactly these individuals are needing. Next slide. So I use the, of course, with we all know as social workers, it consists of the micro, meso, and macro. In a hospital setting, of course, not only do we deal with the patients, we also deal with families, depending on what the issue is. It's not just a patient comes into the hospital for, that they may need housing. We're also dealing with a medical issue behind that. So dealing with individuals one-on-one, also in the meso environment with groups, helping to navigate with the patient and their families, of course. And then in the micro perspective, really trying to help connect with the community partnerships or local or county or government officials on trying to see what resources that we can offer to these individuals in these counties. I have found that in some cases that even if a patient does come in needing housing for shelter, I can only provide that resources for one day to that individual, and they're coming back the next day looking for more housing. So it's really challenging. And then also I have found, even though we deal with mostly family, women and children with domestic violence, there are also men that are dealing with that same issue. And there's absolutely no resources out there to send a male individual dealing with domestic violence at this time. So unfortunately, we have to send them back to their previous location, or we send them back to wherever they are able to go that can help provide a safe place for their environment. So it's really challenging for us working in the hospital setting. Next slide. So of course I use the quantitative methodology for this research. My sample size was the community-based residential assistants, management level, as well as medical social workers. This helped address a lot of the knowledge and skills and expertise that we can help provide to community in the counties out there, which lacks those barriers of sending these individuals back to the streets or where they came from. The worst thing of our job is not being able to provide them help and assistance. And so if we can help navigate some of these issues within the communities which we live in, or partnership with the community organizations, it would really help navigate and getting a lot of these individuals off the streets. Next slide. So I used how I conducted my research. Basically, I used demographic and semi-structured questions. And these are more open-end questions to kind of gain the insight of management and medical leveled social workers on various locations that they have worked at, and how have they have helped these certain individuals coming in and out of the emergency department, and providing a network or a platform and resources that we can provide to these individuals in need. And I'm just trying to hurry up and manage my time. Next slide. With that, you don't have to go to the next slide, but I did recruit, it was 15 individuals who worked in various organizations, of course, but they did have expertise in working into the hospital and homeless shelter. So that's with the management level, medical social worker, and the homeless local nonprofit organizations. A lot of them consist of bachelor level medical social workers and doctorate level degrees in psychology as well. So what I have found basically in my research basically is the gender identities of practitioners identifying, like I had mentioned, their expertise in the fields that they worked in to help navigate some of these issues. And next slide. Just overall in my conclusion, because I'm just trying to be respectful for time. There are times the limitations of these individuals not having a primary care physician has been difficult because it's hard to help navigate these individuals with seeking some of their medication, follow-up care that they're needing. Because again, these doctors in the emergency department, they only help assist their needs in the hospital setting. They really need a primary care to help follow up any additional needs that they may have. And then also additional limitations that I noticed is really trying to help find other resources out there in the community, because a lot of which really depends on the county that they live, to try to help address some of their concerns or issues that they have. There was something I was going to add to this, but overall, what I had designed was a brochure research, basically a brochure to help navigate some of these issues. If we can put all the resources on a brochure that we can hand out to each patient that walks into the hospital setting, that has all the resources in the county and other counties, this can help navigate and provide resources to the patients in need to help limit or decrease them going back and forth to the emergency department. And I try to sum that up as best as I could. Sorry, any questions you guys may have? I know it's time. And at the bottom, it kind of spoke about my the brochure that I kind of wanted to implement to help kind of disperse that to the patients in need and kind of get that out to the clientele. Thank you. These are my references.
Go ahead, Dr. Yamada.
I'll make it quick since we're at time. Then that was really interesting. What was your takeaway, since qualitative research impacts the researcher, because you're there, right, experiencing all of the data and learning from the people that you speak with? Do you have any big impressions on the barriers that are really affecting discharge?
Yes, absolutely. I think a lot of the barriers are really shelters. What I have found, shelters and domestic violence shelters for these individuals to go to. And that's also not only for women and children, but also single women. A lot of times the domestic violence shelters, they only focus on women and children mainly. And I have found that it's really important for there to be more resources in the community to help a lot of these individuals who we don't see. That is a stigma out there that males are afraid to address, that they're being also violated by their partner or what have you, a place for them to go to. So I think there's a lot of work that needs to be done. I've worked in several counties. I worked in San Francisco County, Alameda County, Contra Costa, and Sacramento. And I find that this to be everywhere out here in the northern part of California. So this is a huge barrier that we need to help address. And it is going to take social workers from the macro perspective to help navigate and get the support from the local, state, and government to help address some of these issues in need.
Thank you.
Okay, Dr. Ugo, go ahead.
Sure. The presenter, thank you so much for your presentation. I really do appreciate. I work with this population of people in the community as well as in schools. However, you are mentioning about creating, is it a brochure or flyer that have resources, right?
Correct.
To compile resources together. So one thing I have find out that is not of beneficial or very challenging to this group of people is that sometimes I make a referral to them, or I give this population of people brochure that have the information, maybe wherever there's a resources they can, tap from. However, when I give them this referral brochure, they have it with them, either in their backpack, or if they don't know how to read, or they are discouraged, they dump it. In the end, I still have to bring them back to help them one-on-one, make those calls, assess the information, help them to break the barrier, to break the wall, to actually assess what they need. I find the brochure that it was discouraging for them. When we give them brochures, they are like, so what? Sometimes phone issue, phone problem, or if they are homeless, they're on the street, it's like, what should I do? So I find out that they would come back at the end, and then, we will start from where we stopped when they came to my office, because then I will be like, oh, I'm sorry, can I help you read the brochure? I think one of the things, if I may suggest, if you're creating your brochure, I think it will be of beneficial for us to really find that, those people that can help them bridge the gap, to actually read that brochure, to actually see and help them with those referral or those resources that are inside the brochure already, that they cannot access, maybe because of language barrier, English barrier, not knowing how to read, all those things. That's the issue that I found when I was there giving them brochure,
Yeah, I totally agree with you. I think the only dynamics to that a lot of times, and I absolutely agree with you. A lot of times patients, we hand them a brochure, and that's why we call them frequent flyers. They come in like 2 days later and it's like, well, what is the information? Where's that material that we handed to you? A lot of them don't care, or a lot of them misplace it. So I totally agree. But I think we have to distinguish what our roles are as a medical social worker. We're only inpatient social workers, so we don't carry caseloads. We help address the need when an individual comes in at that time. Most hospitals do have outpatient social workers where they're more caseworkers, more hand holding, more able to, a patient can follow up with the social worker from an outside perspective and continue to provide resources. However, inpatient social workers, we only address patients as they come in, which makes our job limited. It's not something that a patient can continuously contact me for once they leave the hospital. My role stops once they leave the hospital. Also, to your fact, we do send
Dr.
out.
Hudson.
Yes.
I'm so sorry.
Thank
I'm
you
like
so
6
much.
minutes over.
Yes, sorry.
Can I connect you and Dr. Ugo to
Absolutely.
talk
And
after?
and anyone else would like information or more information about it, I'll be happy to put it in the chat.
Thank you so much. I'm so sorry to interrupt you guys.
No, I know my project's long.
It's okay. Right now, I will have our next presenter. Let me share my screen. Oops, sorry, wrong screen.
Is that me? Oh. Oh yeah, it's me.
I'd like to now present Dr. Bailey. Dr.
Yeah.
Bailey is a seasoned
give us
clinical
that.
social worker.
Remember when they were.
Oh, Dr. Hugo, would you mind muting? Thank you. A clinical social worker in the emergency department at Yale New Haven Hospital. She is an active volunteer at the Davenport Children's Community Garden in New Haven. She has been one of the many volunteers who helped rejuvenate this space after the onset of COVID-19. This was inspired by FACE training in the Yukon Master of Gardener program, which was part of her self-care initiative after completing her DSW. Faith also has a private practice and is certified in several modalities of care, such as EMDR, CPST, CST, and CIMI. She also has a history of being a case manager in the Head Start and Readiness programs in Bridgeport, Connecticut, and in Miami Beach. Oops, I'm so sorry. With the Healthy Steps program at the Miami Beach Community Health Center. Welcome, Faith Bailey.
Hi, good afternoon or good morning to all of you. I was wondering if you could run my slides for me because I was having an internet issue with all this wind that we're having today. And to Ebony, you were the one that just did the presentation. Go medical social work.
Thank you.
I feel your pain. I do feel that people do care about their situation, though. It's just that they're blocked, and we have a lot of people that are high utilizers for the homelessness. But I do respect your role. It is a fight every day, and I love that point and change when they're ready to get out of that. So thank you so much. So if I could take you back into a time where right before the pandemic, when we were all seeing people in person, and then we got hit with the change of telehealth and technology change, we could start from there. So I want you to just close your eyes and imagine it's probably January, February, March of 2020. And we are in the midst of change. So my study when I graduated in 2022 was based on how technology enhanced services delivery affected client services at counseling agency, and this was a program evaluation. Flip the next. So I used a qualitative program evaluation and a generic qualitative inquiry approach. This using the type of research approach aligns with change theory and how the integration of telehealth has affected counseling agencies' sustainability. Because remember when we had to keep working and providing services to our most vulnerable populations. Next. I had 12 participants. So in the title, it basically says one agency. I actually used participants from 3 to 4. Three solid agencies were utilized. I had one participant now I remember that I didn't utilize from another one. Interviews with social workers and other licensed professional counselors, interviews with registered nurses, supervisors, case managers, administrative staff, and we had our focus group. It was very interesting to me because I barely used Zoom at that time, and I met with people in person. Some in person, I met with people in this study through Zoom, so I had to literally like reteach myself how to use this mode of communication for the study, in addition to learning with others as a therapist would with their client. Next. So 3 themes emerged, and I was really surprised because I guess maybe information just surprises me. So the first one, the need for social workers to have formal telehealth technology training, because we're using all these different types of systems like Duo, a Zoom. Some people were using FaceTime, some people were using anything, and not all of it was, the most HIPAA complex or approved. And we had to really get down to the nitty gritty of what buttons to push for Zoom, what buttons to push if you're using for um, Zoom Business, and all the different things. So we had to have different trainings. That's what one of the themes that came out. The second was that therapists have different perceptions of telehealth integration and accessibility. Themes arose within this context because of problems with the internet, problems with having private space at home. And the true telehealth training that I remember PESI offered at the time, even before that, as it was emerging with the medical field, quality of assessment, formal training for telehealth therapeutic engagement, communication, and skill set. So how do you tell if a person is psychotic by Zoom? Or what do you do during the session when the Zoom or any type of these different technologies, the signal fades, and what do you do for safety? So there's a whole training that was offered through PESI at the time that we thought that would be helpful. And remember, this is the emergence of telehealth way back when, 3 years ago. Next. So I like this theory, and this is what I used for the study, was the change theory. So crisis happens, we unfreeze in the beginning, then we begin to change and morph, and then we refreeze again with our new processes. And thankfully, telehealth was able to stay in existence because of these changes and unchanges that were needed. So the collaboration with the lawmakers and one of the positive bills that would have been pushed out probably with any president involved, but in the Trump administration, this first round, at least this was approved so we could have telehealth practice as the means to communicate with our clients. Next. What is it? I saw this model. This model was inspired actually by the work in the hospital that I am employed at, because we had a leader that was dedicated to leading us through change. And I tell you, she's still our leader. She's still our director of social work practice. And the ways that we went through it provided the framework for my study, but in a different setting, because most of their work was hospital work. So the hospital, how to stay in your office safely or work from home and call patients in their room. The outpatient practice that I model it for, which was most of the participants, it was like 9 out of the 12, had to change from using most of their offices in person and calling them on the phone lines, through telehealth technology, by video, and any means necessary to provide services. So I appreciate your time. Any questions?
For me, it's more of a comment. I just want to say thank you for presenting. I know during COVID, there was a lot of uncertainty. I think there's still a lot, there's still a lot of uncertainty, right? When we have these kind of black swan events. One thing that, you know, from the optimistic perspective, one thing that I think is good is it propelled the field to go in a direction where we are able to utilize technology in a way that wasn't necessarily approved by the field of social work. So I'm curious to see how the field of social work continues to respond to innovation so that we as practitioners, can serve people now from across the nation, whereas before that wasn't really allowed, right? So I just wanted to make that connection. And despite the challenges that have come from the pandemic, this is something good, right?
Yeah, it was. I think it was something that was coming down the line. So I know medical practices were just starting telehealth medicine, so you could get a little appointment in here and there. So I know it was the catalyst for change. Like, and I don't know, you know how everyone feels like whenever there's a crisis, it gives us the opportunity to change. that that it did open the door for us, and now we're just facing the cost factor and how medical insurances will reimburse us for these services if they're not paying for offices and stuff. So it can open up doors for reaching people in the rural areas, the disabled. All my favorite clients were the ones that I could reach that were bedbound, so it opened up the doors for mental health services. It opened up the doors for not having to take a lot of buses or, childcare. You could have them in the next room playing instead of taking them across town. Some things like that came out also. So, feasibility in daycare, transportation, cost, time, effectiveness. Like it takes an hour to get to your appointment after work. Can you do it during lunch? Can you do it right after work? Feasibilities with internet, room space, room rent, and problems with that as well, because I've had counselors in that study that really had to didn't have a lot of space at home, so they had to be very creative with time and child rearing and responsibilities as well. So it was a definite time for give and take at that very zeitgeist of learning. And there was so many good journal articles that were coming out, because I think I did my study a year within the crisis. So everyone was writing articles. Everyone was sharing about what they were learning and giving us more fuel for how we can make the process better.
Thank you so much. I know that there are a few things in the chat if you want to address them, but I do want to direct this to our small break so everybody could get up and wiggle. So if you want to, you could just answer in the chat. Dr. Bailey, I would appreciate it.
Thank you.
And thank you guys so much. Take a little wiggle break. We'll be back in 5 minutes for our next presenter. Hello and welcome back, everybody. I will share. Dr. J, is it okay if I just share to do your introduction and then you can share? Okay. Um,
All right, wonderful. So I have the pleasure of introducing Dr. Gabbard, who is a professor of social work at Western Kentucky University. His practice background is in the areas of mental health, public child welfare, forensic social work, and work with homelessness individuals and families. He has extensive experience in program evaluation, diversity pedagogy, and community advocacy. Dr. Gabbard, a proud Samoan American, is a former Minority Research Fellow with the Council of Social Work Education, also known as CSWE, a former board member of CSWE Global Commission on Social Work Education, and formerly served as a chair of the board of directors of Phi Alpha Social Work Honor Society International, now serving as a regular board member. His teachings and scholarship expertise include diversity pedagogy, research methods, statistics, HBSC, child welfare, and homelessness. He has presented research at numerous national conferences in the United States, as well as South Korea, Taiwan, Bangladesh, Mexico, and Uganda. He currently facilitates an on-campus support group in collaboration with NAMI for students with mental health issues and recently finished a national study on university faculty mental health. Welcome and thank you.
Thank you so much, Devin, and it's an honor to be here with y'all today. I hope that y'all are safe where you're at. We've been dodging hail here in Kentucky, so it's getting a little wild down here. But what I'm going to talk to you about briefly today is a project that we've actually just sort of finished the lit review on. But hope to start data collection this spring. And that is cyber addiction. This is a problem that has impacted all of us. And everything from cell phone use in the classroom to students. We had an issue where a student was inappropriate on social media, sharing information about their field placement, to obviously students' inability to put away their cell phone while we're lecturing. So it's multifaceted, and I'm going to try to just hit the main points of it today that I've found in the lit review. In terms of a working definition of cyber addiction, basically it's the excessive compulsive use of the internet or smartphones by individuals who rely on it, and negatively impacts their daily life activities, their mental health, and their relationships. There's different subtypes. Some of y'all might be interested to know smartphone addiction is called nomophobia, N-O-M-O. That's something that a lot of our students tend to have, and maybe some of us as well. Video game addiction, net compulsions. My mother suffers from chronic information seeking. She can't stop getting off Wikipedia all the time. So there's different types, subtypes, if you will, of cyber addiction. Some signs that you may have a problem with this is the inability to put the phone down during important life moments. I'll tell you a quick story about this really quick. We were interviewing a student worker for a position, and I was sitting on one side of the table, and my boss, the department head, was on the other side. And the student that we were interviewing, during the entire interview, while we were talking to her, she was texting the entire time. So she was unable to put her phone down during a interview for a position. That got me thinking. It is starting in some ways, particularly in the area of withdrawal, to mimic some of the symptoms of substance abuse addiction. And there are actually now inpatient clinics for cyber addiction. So if you want to tell students cutting edge area in the future to be ready for, the treatment of cyber addiction is one of them. And there's also, what was the other thing I was going to mention to you about that? it just seems like students are unable to put their phone down for any extended period of time. And sometimes that includes us as well. Oh, I know what I was going to tell you. I actually was checking my fantasy football scores one time in church and stepped outside of church to make a change in my lineup. I told that to my pastor after the service, and she said, you may have a problem there. So my boss told me one time that too much of a good thing can be a bad thing. And I think that's what we're facing with cyber addiction. And there's many wonderful things about technology, which I'm going to talk about in a second, but there are also there's a lot of negative impacts of a addiction to smartphones, to the internet, and so on. And as social workers, the other thing I was going to mention is I would not be surprised at all is if this was included in the DSM-6. I know there's one like in the DSM-5, it might be like something related to gambling or video games or something. There's one thing related to this in the DSM-5, but in the DSM-6, cyber addiction is going to be there. I promise you. Mark my words on that. In terms of the scope of the problem and the prevalence, this will be no surprise to you, but the average person looks at their phone about 144 times a day. And most adults spend between 2 and 2.5 hours on social media and on their phones each day. And that's a conservative estimate. Some studies have found even higher with 4 hours. 1/4 of car accidents involve cell phones. And basically, in a nutshell, to sum this up, it has infiltrated every single aspect of our existence. Everything from the family dinner table to recreation and the amount of time that people spend outside in nature, to communications. I mean, I go over to the dining hall and I see it's like people are always multitasking. They're not looking at each other, talking, like having a conversation. They're looking down at their phone, reading, then looking up for a second, then looking down, then talking, then looking up and down. That's become sort of the norm in society, rather than the ability. Another thing, after class, y'all, it used to be after our classes were over, students would talk to each other, what are you doing this weekend and everything. They're immediately on their phones, right, as soon as class is over. Okay, so it's caused a lot of changes in society, and it definitely can impact social work practice as well. So that's why we need to talk about this, and that's why we're writing this article. There has not been in our field the definitive article written on cyber addiction, and that's why we're doing the research that we're doing, because we want to talk about how it impacts our profession. Now, I made the mistake, I was talking about these issues one time with the group here, and I made the mistake of not mentioning anything positive about, so it sounded kind of like I was a dinosaur and I was just complaining, about all the problems that exist. Obviously, there's wonderful things that can happen on site. You can read the list here. In social work, I know I was on an international global commission in CSWE, and we were able to we had a member who was I think she was in Yemen, or it might have been Qatar, but obviously the ability to reach out and have a meeting with somebody across the world is a wonderful aspect of internet connections and so on. To give you another example, there's some students who actually come out of their shell more on the internet and than they do in person. So there certainly are wonderful, and then crowdsourcing, people go on social media, my Aunt Matilda died, people provide a lot of support for that person. So there's certainly positive aspects of cyber connectivity and social media. However, there's also other negative effects. Some of y'all may be aware of this phenomenon. My students tell me that some of them have it. It's basically called texting thumb, where you are texting so much that it actually starts to affect the tendons in your fingers. And some people have had to see hand specialists because their fingers are all out of whack because they text so much. Eye strain has been an issue, headaches, and also sleep deprivation, which is why they tell people not to be on devices right before they go to bed. Musculoskeletal problems, like, when your head's always down, coming up and down, looking at your phone constantly, that's going to cause some medical issues over time. Then also it's impacted interpersonal relationships sometimes. There's been some professors who say that students aren't always able to have like a direct conversation as much because they're so used to being multitasking all the time that it's hard to get them to focus on a conversation. And it also impacts things like asking them to read books. Some of my students who I ask to read an entire book, they look at me like I have another head because the amount of attention that it takes to read a book from start to finish has been impacted by this. Some people believe that their self-esteem is impacted. People see on social media all these perfect portrayals of people a lot of the times who live carefree lives, who have the perfect existence and don't deal with a lot of problems. And or even like physical appearances, people like they alter their pictures to where they look a certain perfect way. And that definitely can impact people's their body image, their image of themselves, and their self-esteem. And research has shown that people who spend a lot of time on cell phones, especially in the classroom, perform worse on exams and on tests. So those are some of the negative aspects of cyber addiction. There's also an increased risk of depression and an increased risk of suicide. Research has established that as well. So as social workers, we're all about interventions, right? We don't just want to talk about what causes something or its etiology, but we want to talk about what has been found that works in addressing the issue. What does not work is asking our students to put their phones in a box when they come into the classroom. Whether we like it or not, the use of cell phones and the connection to the internet has become an integral part of our life. So students are going to have their phones on them and they're going to look at them from time to time in class. I think what's better approach is to teach responsible cell phone usage. Like when you're in the middle of a business meeting, don't be sitting there the entire time texting your friend or looking on eBay or checking your social media to see how many likes you have, how many times people have liked what you posted and things like that. But the treatment modalities and it's a fairly new field, y'all, psychotherapy, family therapy, the use of SSRIs specifically have aided with cyber addiction. Some group therapy. They have digital boot camps where they will actually take people out into the wilderness and take their cell phone away from them for a week or two and get them used to being withdrawn from that electronic device. Because I'll tell y'all, I'm not an expert on chemical addiction. I know a little bit from my doctoral classes, but when you take that phone away from somebody and they don't have access to it, they get nervous and they get anxious. I remember, I think it was, what was it? Instagram went down one day and my students were freaking out about it because they didn't have access to their Instagram account. What does that sound like? It sounds similar to some things related to chemical addiction when somebody doesn't have the substances that they need. Digital detox, a lot of the best stuff that's being done with that is being done over in Asia. Korea actually was one of the first countries to work on this. And then inpatient treatment, believe it or not, for people with cyber addiction. Specifically, I remember an example of somebody who had to go inpatient because of their addiction to the video game Warcraft. They literally could not stop playing that game. And as a result of it, they lost their job. It impacted their relationships with other people. And they actually had to go inpatient to wean them off of being addicted to a video game that connected to the internet where they were interacting with other players and stuff like that. So the writing is on the wall for us as social workers. This is an area where we can make a significant contribution in the future, especially all my, LCSWs out there. But you are going to see this more and more and more over time because it's become, again, it's become so abused and people over rely on this technology so much that it's impacting their relationships, it's impacting their jobs. I watched a guy last semester walking with his cell phone and his headphone on and something else, literally walk into a pole and it knocked him out because he wasn't paying attention to where he was going. It's contributed to increased traffic accidents with people texting while they're driving. I could just go on and on and on about all of the problems if you don't use this technology responsibly. So social work can play a role in this, in that, you know, we're kind of trained to address people, person, and environment holistically. So it makes sense that LCSWs and therapists in social work can make a positive difference in terms of addressing this issue. And I address it just by talking about it in class. Although I will tell you do I have time for one final story?
I saw a student,
I was lecturing, and a student had her cell phone and she was doing this the entire class. I mean, literally the entire class while I was talking. So I walked up to her and I wasn't trying to embarrass her, but I'm like, can you put the device down for a second? She turned the device around and she was taking notes on my lecture on her phone. So that kind of sent me the message that we also have to be flexible in the idea that some smartphones and stuff are being used for different purposes than they were 5 or 10 years ago. And some of them are actually being used legitimately and even in the classroom. So that's something that kind of surprised me and made me think about this whole issue. So anyway, I tried to, sorry, I had to go so fast. I tried to boil down like a long presentation into a shorter one, but that's kind of what's on the table right now in terms of cyber addiction. I preguntas, questions.
Actually, Dr. Gabbard, I'm going to redirect questions to the box, to the Q, like to the chat box, because we
Yes.
do have to move on to our next presenter, if that's okay. So if you guys have questions, please put them in the chat. Dr.
Sure.
Gabbard will be here with us for a little bit longer. He can answer your questions there or ask for his email and you guys can connect afterwards. That would be great. And I will share my screen now.
And thank you for the opportunity. Appreciate it.
No, thank you. Thank you so much for joining us and sharing. That's really important. I think all of us struggle with overusage of technology for sure. It is now my pleasure to introduce Dr. Stephanie Buchanan. They are an experienced mental health therapist specializing in trauma. Dr. Buchanan is trained in EMDR, CPT, and IFS modalities. Dr. Buchanan has spent many years working in adult mental health, nonprofit organizations, and the last several years within her local community, her local county government. She also has a private practice providing therapy services. She is motivated to end stigma and help individuals live meaningful lives. She also has a passion for researching and understanding the roles of mental health disparities.
Thank you so much for that introduction, and thank you all for having me here. I'm going to share my screen. Let's see. Oh, it's not allowing me to share my screen. Do you mind sharing my PowerPoint presentation? Okay, thank you. My research focused on social workers' perspectives on mental health disparities within the Black community and exploring the role of critical race theory, specifically storytelling and counter storytelling. So just a brief introduction, the research aimed to explore those mental health disparities within the Black community and understanding the role of critical race theory within social work practice, specifically storytelling and counter storytelling, My research analyzed 12 social workers' beliefs. All the social workers had an MSW or higher in the field. So some background information on what we do know. We know that Black people have been denied full participation in mental health systems. Black people are receiving poor quality care because of systemic discriminatory practices. And according to the APA, Black populations have the same rate of mental illnesses as the general population. However, they often receive inadequate care and lack of access to culturally competent care. Many mental health disparities are due to bias, racist practices and policies at that macro level, lack of cultural competency and communication barriers, such as lack of understanding. Many Black people are misdiagnosed even when expressing symptoms related to a mental health concern. And what we want to know, so this is information that we don't know yet. I wanted to explore social workers' beliefs about using critical race theory in mental health treatment within the Black community, and whether they can use CRT components such as storytelling and counter storytelling to actually improve services for this population. And also the goal is to identify the underlying causes of mental health disparities for Black people in or seeking treatment. And these are my research questions and how I broke down the data. So there were 12 social workers, but 6 of the social workers were leaders or supervisors. They were in the upper management role. And then we had 6 social work practitioners who were providing direct services. And these are just some of my interview questions that I asked them individually. I wanted to know, like, what are their beliefs regarding treatment differences that they have noticed based on race? In what ways does cultural mistrust cause barriers for Black people seeking treatment? Also, in what ways does the lack of access to culturally competent care affect this population? And then what are social workers' perceptions of interventions that could actually improve mental health? And then shifting to critical race theory, I wanted to know if these social workers knew what critical race theory is. And if they did know, could any of the CRT components or tenets be used in direct practice to minimize mental health disparities within this community? And if social work leaders and practitioners did use CRT in practice already, which components do they use and how do they use them? And I wanted to know if they thought that CRT could be used as a paradigm shift, if they would be willing to use CRT as a practice model, why or why not, or a practice theory. And then I had a focus group with all of them together in the focus group. And I just had 2 specific questions. I wanted to know if storytelling and counter storytelling could be used to build trust and rapport. And if so, why or why not? And I also wanted to know what were their recommendations for improving mental health for Black people seeking or in treatment. And these social workers, I actually use social media to recruit. So it was very focused, very geared towards a certain group of individuals, which were the social workers with a master's degree or higher, and then also in direct practice or in supervisory or macro level practice. And these social workers were recruited through LinkedIn and Facebook social work groups. And all of these social workers came from all over the United States, and they were in all different roles. And this is some of the literature review that I gathered. Research continues to show that Black people are less likely to receive mental health treatment compared to white people. Black people continue to be in multiple systems of oppression, discrimination, and unfair treatment. Studies have shown that Black men are portrayed as criminals and dangerous, while Black women are often seen as aggressive and combative by the media. Black people may not seek mental health treatment or terminate services early due to their symptoms and cultural needs being ignored. White supremacy is about power and acceptance, with which is focused on white history while dismissing Black contributions within American history. And it's also important to acknowledge that most evidence-based interventions have been developed by white men, such as multi-systemic theory and functional family therapy. They were focused on fixing behaviors from a micro level standpoint, so that individual standpoint versus a system, thinking of it as a system issue at a macro level, which causes barriers within already at-risk families when they're just focusing on an individual as a problem versus the whole entire system being a problem. And additional information, there is much misinformation regarding CRT. So critics have cited that critical race theory causes a divide between races, the us versus them, or victim blaming. But CRT would provide a practical framework for social workers to critically analyze and challenge institutional racism and power dynamics at all levels of engagement. CRT allows social workers to gain skills and competency and also utilize an action-oriented approach to address race and create meaningful social change that dismantles injustices. Individuals must fully understand the historical context of racism, the purpose, the goals, and the critical tenets of CRT in order to engage in meaningful conversations and create positive changes within society. Also, research shows that storytelling is an effective engagement strategy for culturally responsive treatment through lived experience and their needs. Counter storytelling is used to contradict, challenge, and expose racial discourse experienced by minority populations. And then this is just some of the data analysis. I use Zoom interviews and audio recordings. This was a thematic analysis. So I use computer assisted software in vivo. And then I kind of clustered different codes when I was analyzing the transcripts from the interviews and generated a thematic map to analyze it. And I would kind of reviewed the functional themes, and then I defined and named those themes. So I clustered the data, the transcripts that had similar meanings, where clustering kind of helped me to group experiences, beliefs, practices, and attitudes from the information from the interview. And then we can skip past this, goes more in detail about the method. But this is some of the results from the thematic analysis when I transcribed like the audio recordings and used that computer assisted database. As far as like the main research question 1, like what are the barriers that cause reduced access to high quality mental health services for Black people seeking or in treatment? So the themes are on the left-hand side based off the interviews. They talked about cost and effectiveness, the affordability. They discussed dynamics of diversity, which focus on cultural consideration, cultural mistrust, and lack of representation. It was also discussed limited knowledge and skills, capacity lacking education, and also just being unaware. Another theme was challenging stereotypes, where a lot of individuals discussed racism and stigma. And then we talked about the paradigm shift, using critical race theory as a paradigm shift. And specifically the storytelling. They were discussing cultural responsive practices and community outreach. And then these are some of the results. I de-identified the participants and I named them as participant 1, 2, and onward to participant 12. But as far as like barriers to mental health treatment, one of the participants mentioned that there are a lot of rumors, a lot of concerns are not being valid, feelings of being misunderstood, not feeling heard, minimizing pain, not having the same pain scale, and also minimizing like their symptoms and the attention, all seem to be the root cause for some of the disparities that participant 1 mentioned. And as far as like limited skills and knowledge, one of the participants, participant 9, mentioned that the lack of education within MSW program surrounding systemic injustice. They had stated that they thought that a critical piece to a lot of MSW programs is that they barely talked about systemic injustices that underserved and underrepresented communities were facing. They go on to discuss the lack of representation within the MSW program. They said many of their professors teaching these classes were not people of color. They may have come from a marginalized community, but they were not a person of color. So they talked about the lack of representation within the MSW programs onward to communities and within hospitals holding these leadership positions in social work. And as far as racism, stigma, and misinformation, they also talked about that racism is not an individual problem, but is more a sickness of society. And then we can skip past some of these, but and these are just like continued results continued results from based off the interviews that I kind of summed up. But some of the representation recommendations that they had mentioned, you can go back right here. They mentioned recommendations for practice, addressing and speaking up about racism practices within your own organization. Also teaching social work practice from an anti-racist oppressive lens within MSW programs, and also being able to incorporate CRT and social work educational programs and in practice. One thing that I noticed that in the MSW, well, not just in the MSW programs, but a lot of individuals who I interviewed, there was 12 of them, only 2 of them actually knew what critical race theory was. They related critical race theory to legal field, which it originated from, and also it being a hot topic as far as education. But when you look at CRT and the tenets of CRT and you match it up next to NSAW Code of Ethics, they align fully. So our social work code of ethics aligns with the tenets of critical race theory. So I think it needs to be more education about critical race theory in order for individuals to actually incorporate it in practice, because there was a lot of lack of knowledge about critical race theory. And a lot of people looked it up before they interviewed with me. But that's it. There's a lot of information on the slides, a lot of quotes from the participants who participated in the study that I, don't mind. You guys can connect with me. I'll put my information in the chat box. Those are the references, and thank you for your time.
Thank you so much. Yes, like Dr. Stephanie said, please, if you need to connect with her, have furthering questions, please put them in the chat. Give your congratulations, everything. She'll be on for a little bit longer and happy to answer your questions. Or if you need to ask for her email, you can do that as well. Okay.
Perfect. Yes, I'd like to introduce Dr. Christina Paddock. Dr. Christina Paddock, also known as Tina, holds a Doctor of Policy, Planning, and Development, is a licensed clinical social worker, and has a Master of Social Work degree. Christina Paddock is an associate professor of social work practicum education at the USC Susan Dworak-Peck School of Social Work. Dr. Paddock recently received her doctorate in policy planning and development at the USC Sol Price School of Public Policy. Her research interests focus on caregiving, working families, child welfare, public behavioral health, and neurodiversity. Before USC, Tina was a program specialist at the Los Angeles County Department of Children and Family Services. In this role, she coordinated the subsidized childcare program for all families served by DCFS. As a licensed clinical social worker, she provided mental health services to children and families involved in public child welfare and with special needs. Tina is also interested in working with neurodiverse children and adults. She was the Wellness Program Manager for South Central Los Angeles Regional Center and advises the Neurodiversity Affinity Group for the USC Susan Dworak-Peck School of Social Work. Her DPPD dissertation assesses how work and family structures shape low-income single mothers' use of childcare in Los Angeles County. Its policy recommendations have been distributed to county, entitled, and community-based agencies involved in making decisions about childcare. Welcome, Dr. Paddock.
Thank you so much, Jerry, for the introduction. And thank you so much for this wonderful event today. And should I just bring up my PowerPoint slides, Nydia? Is that best? Okay.
If you're able to, yes.
Yeah, let me see if I can. Okay, I think I can. Can you, everybody see them okay? Okay, well, thank you so much for the opportunity to present today. I am just thrilled. Actually, the last time I presented my research was for my defense, for my doctorate. So this is the first time I've been presenting it to a group. So again, I really appreciate having this opportunity since this is definitely one of my interests. Being a social worker who has focused on working with children and families, but also being a mother. So there's been a very personal interest in that way as well. So why do we care about this issue as social workers and individuals who, some of you living in Los Angeles? Well, upon doing the literature review and doing just researching this issue, childcare, as many of you know, has always seems to be an issue out there in the forefront. Articles in the newspaper comes up during times when people are running for office. And what childcare entails is childcare means what parents, caregivers use to watch their children. For example, when they work, it could be a formal childcare resource like a daycare center. It can also be an informal resource, such as a babysitter or a family member. What we do know in LA, that there are a number of families with children under 5. I focus specifically on families for this, or single mothers who had younger children for this qualitative study. Because, and I also focused on single mothers because we have at least a quarter, if not more, of the mothers in Los Angeles are single mothers, and many of these mothers live in poverty. I think many of us have seen this if we do work with families as a clinician in social work. If we work with under-resourced communities, we definitely see how poverty connects to the resources that families have. And even if for all families in Los Angeles, it can be a quarter of their incomes to pay for childcare, if not more. So again, this is definitely an important topic to consider. I chose Los Angeles because I really had to tailor my research, my qualitative study, to a certain area. And of course, being in Los Angeles, USC being in Los Angeles, I decided to focus on this. So this is a conceptual framework. I think many of you may have done conceptual frameworks or studied about them in your courses if you're a student right now. So the population I looked at was, again, working low-income single mothers. I actually interviewed 18 for a qualitative study. I was looking at how does family structure, for example, family structure I defined as who the single mothers live with. Living with just children or extended family, how many children they have. I developed all these different, I'm going to say factors, even though it's a qualitative study based on my literature review. And also looking at work structure, I looked at stable schedules, unstable schedules, so the fluctuation of work hours as well as part-time, full-time work. So I wanted to look at how those factors shape working low-income single mothers' use of childcare in Los Angeles. So how many sources you need? You know, do you need just a childcare center you use, or do you need an additional person to help you during certain hours? How childcare, how family helps out during childcare disruptions, and how we can look at policies affecting how policies at work as well as provider practices help or hinder childcare use. So what working low-income single mothers use for childcare. And again, coming from Sol Price, this particular project was very policy focused. They wanted us to have policy recommendations versus interventions. But again, I think us as social workers, understanding policy is so important for the families we serve. So I'm going to end with some policy recommendations. So again, this was a qualitative research study. This is my abstract. So what I did is I highlighted a few areas that I think would be important for me to mention based on the results of my study. So again, I looked at 18 low-income single mothers, and they all attended a subsidized childcare center called Girls Club LA. This subsidized childcare program is not far from LAX. They were interviewed about their experiences with childcare so that they could work. And again, going back to the literature, which I didn't really mention, is also finding out from the literature, I found that, you know, when childcare services are disrupted for a single mother who may not have the option of like support from a partner or spouse or extended family members, it can really, really impact their work. I had one mother I was interviewing here that had no support from family, lived on her own. Her boss would text her to come in to work. She didn't have a stable work schedule. She worked kind of in a rental car program. And this caused a lot of issues for her because not having that stable schedule, having to be on call, and not having, you know, others around her who could help her was really, really impacted her work. We also find that, you know, low-income single mothers are less likely to have formal benefits at work. So just paid vacation days or sick days. And also too, that still, if you do have those supports, mothers still have that, hold the weight of all the mental and coordinating work when it comes to ensuring children are cared when they are working. This is changing a little bit, but my dissertation advisor, Dr. Beckman, did a lot of work on this, and we're still seeing that. But anyway, so those are some of the other reasons too. Sorry, I forgot to mention that earlier. But what I found was, the results that I found through my qualitative study was that, you know, 78% of mothers use multiple resources for childcare, not just a subsidized childcare center, such as Girls Club LA. And when I say subsidized, that means a childcare center where there is government funding going towards the cost. So it's less of a cost for a mother. Interestingly enough, many of them over half used relatives to watch their children. Many of them were grandparents. Again, after reading these, looking at the results, it made sense to me, but I wasn't really looking for that, which was good. So I wasn't going with this bias. I was looking for something. Again, with qualitative research, like Dr. Buchanan, I, looked at themes, and after transcribing the interviews, I looked at themes, and then I also did some quantitative, as you see with the percentages, to get some sort of percentages for some of, looking at some of these themes. So it was interesting. Mothers who lived with extended family or had 2 or more children were more likely to use relatives. The relatives were there. But when you have a lot of fluctuating hours, like I mentioned with that one mother, you just have to use multiple sources versus having a stable 9-to-5 schedule. A lot of these multiple sources, if they weren't relatives, there were babysitters, neighbors, what we call informal resources. And interesting part-time jobs, they use multiple resources than full-time. I wouldn't have thought differently for that, but that's what came. Interestingly enough, a lot of the mothers felt control at work. And the way they defined control was that they had either kind of a flexible schedule. Their childcare hours match their work schedules. This was really surprising, and where I might need to do more research in this area. What they felt like is, many of them felt like they had this informal work support, such as a supportive boss. If they didn't have paid vacation or sick days, the supportive boss would help them with flexibility. I need to come in a half an hour later because I have to go get my child, or I have to drop my child off, or I have to, leave a little early to pick my child up because there's a half day for the childcare center. So surprisingly enough, with this, it wasn't a large group, but that I interviewed, they saw this. So it was interesting how much this informal sport really mattered for these parents. So a couple of the recommendations, again, these are policy recommendations that we can do. And what we could advocate for as social workers is really kind of the supportive grandparents that provide so much childcare. We have a pretty good number of resources for subsidized childcare. In LA County, we're very lucky in that way. There's still some limitations, but just really, what can we do to support grandparents? We don't want to raise the retirement age for Social Security. I know that's coming up a lot in the news now. We don't want to. So, these grandparents can be available, or older adults. Maybe it's not even a grandparent. I had one family I interviewed, one mother I interviewed, and there was a woman within the community that really saw it as her role. She was retired to help others. And Girls Club LA even have a lot of grandparents that were volunteering their time to care for the children. So we don't want to do that. We want to increase the child care tax credit to $3,600 for families with children under 5. I know that always is coming up to address, and it was higher during pandemic times, and it went down. So to really look at that so that families, low-income families, have more resources. We want to involve diverse parents' voices when making childcare decisions. And also to have a website specifically for grandparents who provide childcare. We don't have these resources out there. And then also, we have licensed childcare, and we also have licensed exempt childcare, which are neighbors, babysitters, relatives that care for children. We do have the ability to have government funding towards that at this time. A lot of grandparents do not know about this. A lot of other relatives that care for children do not know about this, that they can pay vouchers, that families can get vouchers to pay grandparents. It's not as much, it's not a lot of money, it's not minimum wage, but it is a little bit. And if the families meet certain income requirements, you can get that funding. We have childcare resource and referral centers throughout Los Angeles County that can help with that information. We also want to make sure, some other ones I wanted to emphasize is if we can formalize flex time policies for all workers. These are some worker-related policies. That would be wonderful. In our USC, we don't have formalized flex time. What that means is you could come in a little later if you need to drop off a child, or leave a little earlier. And that's formalized versus like kind of an informal thing you do with your boss or to agree on with your boss. Also, LA has this Fair Work Week ordinance that they're working on, which is basically, this ordinance says that companies with 300 or more employees need to give the workers their schedules in a timely manner, not have like the last minute, that they know their schedules so that it's more stable. Right now, businesses with more than 300 employees have to do this. They don't always follow it. There's a $500 fine. Some just say, forget this, I'll just have the fine. We need to do more work and have it also where organizations that have less employees also need to do that within the city of Los Angeles. And also in terms of what can childcare providers do, provide different scheduling options, including holidays, evenings, weekend, sick childcare. Many of our childcare providers don't provide as many of those options. Maybe it's hard because of funding. We could provide incentives to childcare providers who offer these non-traditional hours and sick childcare through some of these subsidies, some of these government programs we have. And we also need to continue to survey parents about their scheduling needs and how they use multiple sources. I couldn't find a lot of research in that area, in particular with Los Angeles. It was more like affordability, looking at affordability, or finding resources, accessibility, or quality, but not how multiple sources are combined to support families. and especially single mothers. And also one thing, Girls Club LA, where I did my research in Los Angeles, they provided other ways for families to connect and single mothers to connect outside of providing just childcare services. They had a food drive, they have different activities, they involve grandparents in the community to help the single mothers as well as other families there. And that really, I think, helped those connections, those networking opportunities really created that social support and less isolation. I think I'm doing this is my last slide. I think I'm doing okay with time. So what about future research and plans? I think with my research, I found out a lot came up with what a supportive boss. A lot of the mothers, single mothers I interviewed said, I have this supportive boss and they help me in these situations when there's a disruption. I could turn to them. I was again, it wasn't a big research. It was 18. It was a qualitative research study. It wasn't quantitative, but what does having a supportive boss mean? I would love to explore that a little bit more. I'm also was curious, and somebody brought this up when I presented my research, were there any gender differences with that? And do certain genders support or implement family-friendly policies more? So I think that we wanted to look at those gender differences and what it meant to be a supportive boss. There's not a lot of research in that, so I think that may be a gap. And then also another gap was what control in the workplace. I was very surprised to have these mothers say, I feel a sense of control in the workplace. Again, I had certain assumptions. We always want to put our assumptions aside when we do research or at least be aware of them. But I like to look more at how this is defined and if it's different than the literature. And I looked at some of the literature. I couldn't find a lot of literature in this area, but look at that and what that means, because that could be a really good piece of information to have as we're developing either work or policymakers or childcare providers are looking at family-friendly policies. It might be a really good piece of research for them. What I did is I did share my recommendations with, again, I mentioned with our Los Angeles County Child Care Planning Committee. They helped me a lot with getting with my research sample. They're the ones that make all the decisions for funding for childcare, subsidized childcare in Los Angeles. And then, of course, with Girls Club LA, I did another small study for them, a survey, so they can learn more about how they're serving their families there and what other sorts of resources families might want. So they're a wonderful organization. If you want to check them out, they have a great website. And again, they do, besides offering subsidized childcare, they also offer a lot of other different resources for the community and really embedded in the community. And, some limitations of my study was, again, wanting to have a larger sample, of course, and, again, looking at some of these areas in terms of what I saw maybe needed additional research. But yeah, thank you for letting me present today. Bye.
Thank you so much, Dr. Tina. If we're going to move on with our next presenters, because we are a little bit behind actually on schedule. So if anybody has questions, please put them in the chat like our previous two presenters. I'm sure Dr. Tina can take some time and answer your questions. And if you need, you guys can share emails or exchange so you guys can ask furthering questions. Thank you so much. And
Thank you, Nydia.
You're so welcome. Okay. So our following presenters are Erin Johnson. I'm so sorry, my share button is blocking what I'm going to read. Erin Johnson is an MSW. She serves as the Associate Dean for Behavioral Health Sciences at George Fox University. She previously served in multiple positions within the Department of Social Work at George Fox University, including the BSW Program Director, BSW Field Director, MSW Field Director, and Associate Professor of Social Work. Prior to teaching, Erin worked as a mental health therapist with a focus on play therapy, family therapy, and trauma-informed care. Her current research focuses on the development of trauma-informed teaching, practices, and policy development. She will be accompanied by Christine Soldino. She serves as the MSW Program Director at Eastern Oregon University, bringing over 18 years of higher education leadership experience to her role. As a social work educator and administrator, she has successfully led the development, implementation, and evaluation of social work programs, ensuring alignment with Council on Social Work Education accreditation standards. Dr. Saltino is committed to fostering an inclusive and empowering learning environment that equips students with the knowledge and skills necessary to become competent professional social workers. Drawing from her experience in both online and in-person teaching modalities, her educational approach emphasizes creating transformative learning environments through student-created trauma-informed teaching methods that prepare future social workers for professional practice. Dr. Saldino holds a PhD in Human Services from Capella University and a Master of Social Work degree from the University of Central Florida. Her research interests focus on trauma-informed teaching practices and policies, innovative approaches to online social work, education, and social work ethics.
I think, Erin, are you going to share our slides?
Yeah.
All right. Well, she's getting that set up. Thank you all. It's such an honor and a pleasure to be here with you today. And I'm just loving hearing all the various research that's going on. Erin and I are both in leadership, as you could see from the introduction, within educational institutions. And so we bring that to our work. And we know that trauma-informed practices have really evolved within social work practice. And we're seeing that with teaching practices, although less information in social work literature specific to that. But then we began thinking together about, well, what does this look like when we apply it to our policies, particularly policies in our social work programs? And we began by really searching the literature and didn't find a whole lot in regard to that. And so we've been looking to think about frameworks and how can we do this work within our own various programs that we've been a part of. And we're hoping to do some additional research in this area this summer. We'll continue doing work on this. And so that's what we bring to you today. Next slide, Aaron, please. I didn't want to assume that everyone knew what trauma was in the room, especially not knowing who was going to be here. And so some basic definitions of trauma, one coming from the Body Keeps Score, which if you've not read that book, I would highly recommend it. But trauma is something that happens to you that makes you so upset it overwhelms you. Or coming from SAMHSA, that's an individual trauma results from event or a series of events or set of circumstances that are experienced by an individual that results in harm, right? Both physically or emotionally harmful, and can have lasting adverse effects. We know that people that may even go through the same traumatic experience don't necessarily have the same effects, and that's based on a lot of different things. So trauma being everything from experiencing, right now I'm in Tennessee, so we're going through some weather events also as well, like a colleague from Kentucky had spoke about. But we could think about displacement like with Hurricane Katrina, or we could think about maybe a loss of a loved one. We know from the ACEs research that we see the effects of trauma or potential effects as it relates to health and those kinds of things as well. And we know within the literature also that within social work education, students both bring traumatic experiences to social work education, but they also experience trauma through our curriculum, even in their field placement or practicum placements. They're experiencing traumatic experiences as well. So next slide, please, Erin. One of the frameworks that we have begun to think about and apply here comes out of Trauma-Informed Oregon. It's the tool is much more in depth than what we have in the slide given time, but it helps us to begin thinking about, particularly in agency settings or in higher educational settings, how are we ready? Are we ready to even begin applying trauma-informed practices in those settings, right? And so it's important, you begin on that first phase is that trauma aware. We have one person or maybe multiple persons that start to think about, hey, we need to begin, thinking about how do we do these trauma-informed practices in our particular setting, and it moves all the way through to that funnel where we've gotten more training, we have the resources that we're putting working towards those practices, and then we're actually implementing them and monitoring and making adjustments kind of in that phase 4. And so as we think about our own, in particular, again, agency or even within higher education settings, there's an assessment piece of understanding where are we in that, and are we prepared to begin implementing and thinking about changing our policies so that they're more aligned with trauma-informed practices. And I'll turn it over to Erin to speak from there.
Yeah, thank you, Christine. So this readiness for change screening tool is really important as we start to think about policy change and development. Just because one person of a team is trauma-informed, trauma-aware, trauma-sensitive, it doesn't mean that the whole organization or the individuals within the organization have trauma awareness or sensitivity. And so we really want to make sure that when we're looking at policy development that we take a few steps back to first assess the system that we're looking at, and to make sure that the agency itself is in this phase 3 space. And so some of our work sometimes starts with at phase 1 with an organization and looking to want to change their policies, and then we have to bring them to a space when they're ready. When an agency or organization is ready to assess policy or develop policy that's trauma-informed, SAMHSA gives us a really good outline for a trauma-informed approach to policy assessment and policy development. So all of trauma-informed care and response follows the realize, recognize, respond, and resist outline from the Substance Abuse and Mental Health Services Administration. Making sure that an organization at the policy and procedural level, as well as the service elements, realize that the prevalence of trauma and how it affects a person. There's a recognition of the signs and symptoms of trauma, and that we respond through an integration of trauma knowledge into our policy and practice. And then we resist re-traumatization. So Christine and I, both working as social work educators and in leadership in social work programs, recognize that we both had policies in our respective programs. Christine was at a different university at the time that we started this. Recognize that some of our policies and procedures within our social work education program were not trauma informed, we're not centered around the student experience, and we're not culturally informed. And so what we did was we created kind of shortcuts within our own programs to make exceptions from policies that we either had created or inherited that weren't working well for our students because they weren't trauma informed. And so from that realization and from some of the work that we have done previous around trauma informed care and trauma informed teaching, we moved into looking at trauma informed policy, trying to develop policies that are safe, are trustworthy and transparent, utilize peer support, engage in ways that are centered around collaboration and mutuality. That there is empowerment and voice and choice of those who are affected by the policy, and that our policies are culturally, historically, and gender inclusive and attuned to issues that have historically and currently impact vulnerable populations. So how we did this was we used these 6 areas of policy, trauma-informed policy given to us by SAMHSA, and developed a questionnaire to look at how do we assess and create new policies. So at George Fox, in our BSW program last year, we used this screening tool and model to reassess our attendance policy, our no late work policy, which is now our work submission policy, as well as our professional behaviors in the classroom policy, centered around student experience and student choice, creating empowerment of the students to communicate their needs in a way that is supported and responded to by their professors. So some of the questions, and I'm trying to be cognizant of time here, some of the questions that we utilized in policy assessment is in the safety category. Who is the policy created for, and who is the policy designed to keep safe? Oftentimes in higher education, policies are developed to protect professors. to provide guidelines for professors and how we respond to students. And we tried to really look at what do students need in this policy? How can we create policies that are student-centered, that are focused on the cultural needs of our students, that are focused on the familial needs of our students, and that are trauma-informed? So you can see in these slides some of the different elements of policies related to safety, trustworthiness, transparency, and then collaboration and peer support. This next slide here looks at the last three around empowerment, choice, and intersectionality. One of the things that we really recommend, and this is supported in research around creating trauma-informed, culturally attentive policies, is to really understand the service users and who the policy is set to support and empower for positive, life-changing experiences. An example that I can provide in a way that's trauma-informed and intersections with cultural needs is we had a student who needed to travel back to her country of origin for a family emergency. We wanted to support her travel. We wanted to support her presence for her family, but it impacted her ability in our classroom based on our attendance curriculum or our attendance policy to pass the course. And so we started creating workarounds for the student. This same student also was responsible for driving her younger siblings to school or providing childcare for her younger siblings when her parents had to work. And so we recognized that we needed a policy that was attentive to some of these different things. And so we created new policies, and some of the work that Christine has done as well focuses on developing policies and procedures that are trauma informed. We know that we have to back up from wanting to just focus on practice that's trauma informed to work in places that have policies that are trauma informed as well. And so this is some of the research. I know it's a very brief overview and we're trying to be cognizant of time, but it's really important work that we are doing and that we are encouraging other departments in our universities or other agencies in our communities to consider as they move into trying to create trauma-informed policies. And so I'm going to end as there because, of course, like all of us, we can go on and on about our research, but I want to pause and we can either move to questions in person for a few minutes, or if you want to move to putting questions through the chat so that we can track on timeliness, that works for both of us. But thank you all so much for having us and giving us a space and time to provide a brief overview of this research.
Yes, thank you, Erin.
Thank you so much. I appreciate you guys. I think we have enough time for one question if anybody wants to have a verbal question, and then we will move on to the chat. Go ahead, you can ask. Oh, you are on mute.
I'm sorry, I didn't mean to raise my hand.
Can you hear me?
I didn't mean to raise my hand. Can you hear me?
Yes.
Yes.
Okay, it was a mistake. Sorry about that.
Yeah.
Okay.
I'm trying
Well,
to put it down.
I actually did raise my hand though.
Oh, it seems like somebody else is
Yes,
using
I
the...
did.
Okay,
Yes,
go
I
ahead.
did. I actually raised my hand. So I was just listening to the last lady talking, and she mentioned something about the trauma policy. So the policy, because I was just going through it, and sorry I came a little bit, I joined late because of the connection. And reading it, it says the empowerment which button up policy making and shared decision. So are you guys more on like a consultant where you help one to write up a policy in the mental health field?
Yeah, go ahead, Erin.
At this point, we have done it with our own teams. And what we're hoping to do over the space of the summer is to create a pathway to work with organizations that are interested in utilizing our screening process and our assessment tool as part of a research design project in understanding how utilizing a trauma-informed policy screening tool and assessment tool can lead to more trauma-informed policy. So that's like our next step, is to take what we have developed and identified as ways forward and utilize it with other departments, other organizations, or community partners.
Okay. And also you guys also have there when it comes like the IAP and the EAP, does that include in part of the policy? I'm just asking. Can you hear me?
I can, yeah. What can you
I said
expand on
my
that
question
acronym?
was like, yeah, my question was, do you guys also include like the IAP and the EAP?
What is IEP and AIP?
Oh, IAP more like sorry, it's more like a emergency preparedness plan.
We have not at this point integrated that into our policy assessments at our program level. I think for us, that would be something at our universities that we would look at on a larger scale.
Okay.
Thank you so much.
Yeah.
Thank you so much.
You're welcome.
I appreciate the questions. I think also if you guys want to check in the chat, I think there's somebody that wants to connect. And I will now share my screen to have our next participant.
Next, we have presenting Eric Jones. Eric Jones brings a unique convergence of lived expertise and academic insight to the field of addiction recovery. His journey through justice involvement, homelessness, treatment systems, and misdiagnosis transformed into a powerful catalyst for innovation in environmental response design. As an MSW candidate at California State University, Los Angeles, Eric develops transformative frameworks, that recognize environments, not willpower, as the primary determinant of recovery outcomes. An international speaker who has presented groundbreaking research in Cuba, India, Spain, and Costa Rica, Eric draws from experiences across 40+ countries to identify universal patterns in how environments shape human potential. His work with LA County's Justice, Care, and Opportunity Department and the Amity Foundation demonstrates how environmental transformation creates sustainable recovery pathways where traditional approaches fall short. I'm an environmental architect specializing in places where there's nowhere else I'd rather be, Eric explains. Recovery Compass emerged from recognizing that 95% who never engage in traditional treatment aren't failing the system is failing them by ignoring environmental realities that determine success. Eric's approach represents a paradigm shift from expecting adaptation to unchanged environments towards creating contexts where recovery becomes the path of least resistance. Welcome, Eric Jones.
Thank you very much. Just trying to figure out this presentation mode. Of course, it's not working. Okay, there we go. Good. Okay. Yeah, so before I dive into my research today, I want to make one thing very clear. This is more than just my capstone project. This is my life's work. And this will remain my focus long after today because it is rooted in my own lived experience. And for over 20 years, I was part of what Los Angeles County departments, those managing the largest substance abuse treatment budgets in California, refer to as the invisibly suffering population. And I spent half a year navigating the full spectrum of the formal treatment system, detox and residential treatment, sober living, outpatient care, AA meetings, and even as a client of the Department of Rehabilitation. But what truly allowed me to cross the chasm from struggling to stable wasn't just those services, it was the unofficial support system that existed beyond them. And that reality is what drove me to turn this research into something more. So 2 months ago, this project became Recovery Compass, a nonprofit dedicated to reshaping how we approach recovery environments. And I named it after my partner, Naha, who was my compass when I couldn't find north. And I founded it for my mother, whose support never wavered. And I built it alongside Amani Jackson, who was my group therapist in residential treatment, the person who inspired me to apply to the MSW program at Cal State LA. And Amani was the first to believe in this vision. And today she's not only my mentor, she's here as Recovery Compass's first board member. Amani, thank you for being here today. And this is why I stand before you, not just as a researcher, but as someone who has lived both sides of this issue. And today I want to show you why changing the environment of recovery is the key to transforming the system itself. So,
Eric, I don't think your screen is sharing.
Oh, sorry. Sorry about that.
Thank you.
Can you see it? Yeah.
Yes.
Oh. That was the first slide. Okay. And okay. Is it? And yeah, so for over 20 years, I navigated life as part of the invisible 95%. Individuals with substance use disorders who never successfully engage with addiction treatment. And my journey from substance dependence to founding Recovery Compass isn't separate from my research, it's the foundation of it. What I discovered and later validated through research is that our addiction treatment system consistently fails the majority, not because they lack motivation, but because it fundamentally misunderstands recovery. And this realization led me to create Recovery Compass, the first founder-led nonprofit in Cal State LA's history for the Masters of Social Work program, built entirely on environmental transformation. So traditional treatment forces individuals to adapt to, there we go. There we go. Adapt to unchanged environments, asking them to essentially swim upstream. And Recovery Compass inverts this. So we transform the environment to make recovery the path of least resistance. So, sorry, I've got a little bit of a tech issue here. So the data is clear. When I returned to an unchanged environment post-treatment, relapse wasn't a personal failure, it was a systemic inevitability. So we must stop placing responsibility solely on the individual and start designing environments that support recovery. So let's look at the numbers. Housing, stability, and employment, 86% success with an environmental focus versus the drug being the focus, versus 44% in traditional models. Sustained recovery rates, 87.5% with an environmental focus versus 53% in traditional drug-focused systems. And the ROI is $1 invested equals $4 saved in healthcare and criminal justice costs. So these aren't small improvements. This is a systems level transformation. And why then does our system continue to resist environmental intervention? So traditional treatment creates a structured, monitored, research-rich environment. only to release people back into instability. 85% relapse within 1 year, not due to treatment failure, but due to environmental mismatch. We teach people to swim in one context and then expect those skills to transfer to entirely different waters. And this is where Recovery Compass changes the game. Recovery Compass integrates 3 components to create sustainable recovery environments. First, the environmental assessment. So it maps risk factors across physical, relational, and economic domains. So right now, I'm on the front lines working at Amity Foundation, Housing First for the reentry population, where they have severe mental illness, many living with schizophrenia. Many have spent, 15 years in jail in gangs. Most are of Latino and African-American descent. And, in these situations, you might ask, well, how can we make the environment, the focus for them when it's very limited, their options, right? Well, simply, right now, the majority of my clients that are relapsing because they go into a drug treatment facility where you're supposed to address the drug substance abuse, and they're relapsing because other patients are selling or using drugs in the system. So simply by taking that into account and asking what it is that is causing the relapse and putting them in facilities that may not have drugs inside them and that are close to where they get dialysis, or they have to attend their anger management class, or that exercise is big for their recovery, so it's close to a park. So even these minor adjustments, if you're not able to just relocate to Hawaii and live on a hammock on the beach and change your environment that way, it's critical. It can be the difference between life and death, really. And then personalized intervention. So I'm right now in a pilot pathway towards becoming the first evidence-based practice of its kind, where it's not designed until it meets you. It's designed after the assessment. So if you guys have ever been through anything and someone says, I have a solution that was designed just for you. Well, not really, because it was designed not having met you ever. And when it meets you, it expects you to adapt to the treatment that was designed before it meeting you. And this is only designed after a thorough assessment and designed in a way that has never been designed for anybody else. And second, relational capital. So I find oftentimes it's more important the person providing the evidence-based practice than the evidence-based practice itself. So taking that into consideration and giving people a chance to assess for the relational capital between them and the provider, because someone like a veteran coming back from a war that just had a drug problem since the war might want to meet with a provider that's a little different than someone that's been living on Skid Row for 20 years with a heavy meth addiction, right? So this isn't just theory, it's built from real world failures and successes. And we move from a 5% focus on individual behavior to a 95% focus on systemic design, from adaptation to barriers to the creation of support, and from crisis management to sustainable transformation. And when environments transform, recovery follows naturally. Thank you, and I welcome your questions.
Thank you for sharing. What an inspiring story. I hope that we all are able to take from this and learn. If you have any questions, I do want to be completely transparent and let you guys know that we are running about 10 minutes behind. So I will move the presentation along, but if you need to connect with Eric, please do so in the chat. You could send him a message, send your email, however you would like to connect. That would be wonderful. I think that the information given today has all been very impactful. Thank you for sharing your story.
Thank you, everyone. It was a pleasure.
We can somehow have Yvette. I think her hand was raised. Maybe just take one comment for Eric.
Sure.
I just want to let you know that I really enjoyed your presentation. It was very amazing. All these experiences and the studies you have obtained throughout your experience. I do acknowledge the lack of services that a lot of people with substance use have individuals been facing, and I really appreciate for sharing this with us. Thank you.
Thank you, Yvette. I appreciate it. And I'll put my contact information in the chat. Thank you very much.
It is my pleasure now to present Olivia Sase. She is a BSW candidate. Olivia Sase is from Bowie, Maryland. She is a graduating senior in the School of Social Work at Clark Atlanta University. During her first year, she was awarded the highest first-year honor award because she maintained a 4.0 GPA during her freshman year. Since then, she has been awarded the Dean's List Achievement for the past 5 semesters. She's worked with young children from the age of 10 months to 17 years old for the past 5 years. Currently, she is a social work intern at COR Inc., which she works with high school and middle school students, assessing and serving their needs. She is also currently serving as the treasurer for the Organization for Social Change, an organization with like-minded social work students and other majors to address social issues not only on her campus, but worldwide. A few of her research interests include the role of social workers in addressing elder abuse and neglect, and the role of social work in end-of-life decision-making processes. Another interest is the high rate of homeless African American youth. And another interest is research on policy and system change.
Hello. I'm trying to share my screen. Did you want to see my screen?
Yes, we could see it.
Okay. So my research title was Striving for Success, Academic Outcomes of First Generation College Students. So I studied the different factors that impact one's ability to succeed at higher education facilities, such as colleges and universities. And the specific factors I focused on were parental support and involvement, financial responsibility, and psychological factors, such as stress and imposter syndrome. So my research questions were, is there a relationship between parental support / involvement and academic performance of first generational college student? My second research question was, is there a relationship between financial responsibility and the performance of first generational college students? And the third question was, is there a relationship between stress or imposter syndrome and academic performance of first generational college students? So from some research that I did prior to this research, a study found that it was more students that were more difficult students that were more independent had more difficulty with academic tasks, and those that went farther away from school had their performance did decline. But first generational college students had higher grades and lower dropout rates compared to those who had a parent that went to a four-year college. So how I found my data for this research was I collected the data and then analyzed it after I got 36 students from different backgrounds, from different ages, different genders, different institutions they attended. Majority of them, 61% of them went to PWI, a predominantly white institution, and 15 students, so about like 40 of them, went to a historically Black college university. And I did a survey, like asking them questions about, like, do they work while in school? Do they feel overwhelmed? About 83% of them do work while they're in school, and 77 of them felt overwhelmed with their workload, academic workload. So, and then I analyzed the data with the SPS software. And I used their GPA. So the survey did ask them their GPA on a 4.0 scale to correlate if there was a relationship with it. So this is some of the descriptive data. So like I said, a lot of them had supportive parents with their academic achievements. Less than half of them did feel satisfied with their academic performance, and I think that goes to because they have other financial responsibilities that they do have to maintain while working, but they also did not feel pressured being a first generational student. So as a result of the research, there was no significant relationship between any of the factors that I studied. So there was no significant relationship between parental support and academic performance. Most of them had a GPA between 3.1 and 4.0, so a high GPA. And the students that did have a lower GPA didn't really have parental support. And secondly, there was no significant relationship between financial responsibility and their academic performance, but they all had a way in which they managed their college expenses. At 3, there was no significant relationship between imposter syndrome and academic performance. And those that did have a higher GPA said that they've never or rarely experienced imposter syndrome. But those that did experience imposter syndrome occasionally did have a lower GPA. So, oh wait, hold on. I have another part that I was gonna say. Okay. Well, I was just gonna say as for the social work practice, I said social workers can encourage the students or their clients that are students that they have to involve themselves with more self-care while in school, and also encourage their parents or whoever their support system to be involved, or at least show like gratitude, like, oh, we're proud of you, or you're doing really good, because that can make people want to achieve more, knowing that their hard work is not going unnoticed. I'm done. How do I stop sharing? Oh, stop. Oh, okay.
Thank you so much
If
for
there's any
sharing.
questions.
Yes. Please, if there's any questions, if anybody has anything that they would like to say. In the chat, there's a comment, says, thank you, Olivia. This is an important study. Well done.
Thank you.
Okay.
Validation. Wait, yes.
Okay, I am going to move to the next presenter. Give me 1 second to pull up my screen. Okay, it is my honor to now present Dr. Ugo. She has over 20 years of experience as a dedicated multicultural family and community social worker, providing social services to individuals, groups, couples, justice-involved youth, families with child protective services, and immigrants who present with histories of complex, unresolved mental health issues, social legal problems, and various socioeconomic, cultural, ethnic, educational, and other diverse backgrounds. She virtually provides capstone and dissertation consultation to individuals in higher education to support their goals of achieving their degrees globally. She currently works with school district advocating against students' disability labeling. Dr. Ugo is passionate about assisting homeless, historically underserved, vulnerable populations to accomplish and achieve their utmost potential needs for stability. Dr. Ugo, you may share your screen.
Oh, I sent it to you in advance so you can share from your end.
Okay, I could share it.
Oh, yeah, sure. Thank you.
No worries.
Thank you. Should I go ahead?
Yes, please.
Okay. Good afternoon, everybody from Minnesota. My name is Dr. Ugo. I studied my Doctor of Social Work with Capella University. And the topic of my research is social workers' perspective of integrating cultural screening for Nigerian children in school. So it's actually for Black children or African children in school. However, you know you cannot collect data when you say, you can't call it, it's too much to say African because that's like a whole lot of people. It's impossible to collect data from African. So that's why I just say Nigerian. So in this research, I used the participatory action research using case study to explore the early childhood special education observation screening for Nigerian children and their families. So the background of this research is that I work with the Early Childhood Learning Center from newborn 0 through 3 years. And then from 3.5 years to 5 years, they bring them to school district. So in the school district, multidisciplinary teams, including social workers, psychologists, nurses, and other specialization background. So they will look at a kid that is brought by their parent. They will eyeball a kid and say, this kid has disability. This kid does not have disability. And I am against that because you cannot just observe children and decided that they have disability. So that was why I had to research or investigate the program to see, are they really helping the children or are they just labeling Black children? And if you may want to know what the screening program is, so it says the screening program is a process where social workers and other specialization, practitioners use observation as a tool to assess and observe Nigerian children aged 3 to 5 years in schools to determine if there should be a referral for further evaluation. Next, please. Next. Okay. So I use, sorry about that. Go back, please. I'm sorry. Thank you. So qualitative case study is a method that I use to explore cultural integration approach through interviews with 5 members of the multidisciplinary team, which are the teachers, 5 teachers. And then I also use the 5 social workers and 5 social workers who are community social workers. And I also use the 5 parent individual, which I interviewed individually for triangulation. So I use a total of 15 subjects, 5 social workers, 5 teachers, and 5 parents to come up with the outcome of this research. So the reverse NASW Code of Ethics highlighted that community social workers and school social workers play important role in initiating the implementation of the service to improve integrated community initiative to support the well-being of all individuals, providing micro, meso, and macro resources for our population of people. Next slide, please. So in this research, there were 2 overarching questions that came up. So the first question is the main question, and then 1 sub-question. The first question that we resolved, we were able to answer during this research was, what are the perceived benefits of social workers and other practitioners implementing cultural integration in the observation screening for Nigerian children and the families in screening program? And the sub-question was, how do social workers and other practitioners apply cultural intervention in the observation screening program for Nigerian children in the Midwest school? So the 15 people that I interviewed wanted to know how the school system actually applying cultural integration, cultural observation screening in these screening programs in school. Because, for example, in Nigerian parents, we advise our children not to look at somebody's eye, not to make eye contact when adult is speaking with you. That is based on our value, our respect, and background. However, when parents bring their children to our school then to observe them, then the professionals are saying that children are experiencing disability, or they have this, they are disabled just because the children are not making eye contact to adults who are speaking with them. I remember one of a time that among parents, both of them were crying, during this observation screening. So these Hmong parents, they were expressing their feelings, saying, I teach my children to run away from strangers. And here we are, I brought my children for your observation screening, and you're telling me that they qualify or they pass. The professionals use pass or fail. So these Hmong parents were saying, how can you qualify my child, saying that she is disabled just because he's not making eye contact, just because I taught my children to run away from strangers, and here in your school, you're saying that because they are shy, they didn't answer your question, they qualify to be a disabled kid. Next slide, please. So the problem statement that actually made me to go into this research was saying Adam and Taylor indicated that approximately 84,000 immigrants students enrolled in K to 12 classrooms with more than 4.6 million English language learners, which the school addressed as ESL. And Snyder et al. Also highlighted the increased enrollment of students of color in public school from 41 to 50.3%. And there is a projected 54% of non-white students enrolled in K1 through K through 12 schools in 2025, which you can see that is a problem. So if we have this amount of students, you know, look at this one says Ado and Etel says 4.6 million of English language learners. So if we have all these children in school registering, you can see that when we don't have the people of their culture teaching these families, you know, using their alphabet, they have a different way they read their alphabet. You know, here in America, we say A, B, C, D. You know, back home, we say A for A, C for car, B for, you know, A, B, C, D, instead of saying B for ball, C for car in American usage of alphabet. So you can see it is a problem, looking at the problem statement. Next slide, please. So the research findings and the research goals was saying, you know, the development of curriculum, identifying cultural specific approach that multicultural or multidisciplinary professionals in community-based social workers and other professionals can incorporate into screening program for Nigerians. So I just mentioned that. So if you do not have the way Nigerians read their ABCD and you don't have cultural integration, their cultural background, you don't have their parent input. So how are you going to, you know, teach that the children from that culture? How are you going to label that they are disabled when you do not even know how they learn or the background in their learning areas? So the second one says that we need to also provide a recommendation to implement culturally specific approach appropriate for Nigerian children. Then we need to also enact the principal recommendation to implement the researchers developed culturally specific curriculum, provide adequate opportunity for evaluation of the curriculum annually for consistency for best practice. So when you look at my research, about 200 pages that were written about this research, there are so many different recommendations that we are asked to, the 15 people that I interviewed for this research had recommended that, for example, for you to teach our children, you have to know how we read our ABCD. For you to teach our children, you have to know how to sound Ugowai and know what it means, instead of just assuming what you're teaching them or assuming or labeling the children for disability when they are not disabled. Next slide, please. So recommendation that came out from these 15 people for best practice, 15 people meaning the subjects that I interviewed, 15 communities, 5 community social workers, 5 teachers, 5 parents. So the recommendation we came up with was that the researchers, the screening tool that should be used to screen the children of Nigerian descent must be culturally relevant to the ethnic group that it was designed to help. And the screening tool also must be individualized and they must be specific. B says the screening tool must be adequate and function effectively and should meet the requirement and the standard for which it was intended for. And according to Mackenzie has stated, he says the amount of time involved for the assessment must be brief and straightforward for you to use those screening tools. Next slide, please. Oh, thank you so much for this opportunity, inviting me to present my research. This is the first time that I'm presenting it in the community. Is there any question?
I don't have a question, but I do have a comment. I feel like that your research is very relevant even here with other ethnic groups because I've seen this like with Asian children and how, you know, it's part of their culture to not look at people in the eyes, especially their elders, you know, how they have to respect. And so you're right, a lot of times that's misconstrued as something else. But it's just something that's culturally appropriate for them. So I appreciate you sharing your research.
Thank you. Thank you.
I would just echo that appreciation. I think your research is such a strong example of the intricacies of culturally informed and culturally aware practices that is so important for us as social workers. The examples that you give just in this short presentation about pronunciation of ABCs is something that's so tangible it will be easy for me to take back to our students to share in terms of how deeply and how specifically they think about their approach to being culturally sensitive, culturally aware, and trained in their practice. So thank you so much.
You're welcome. Thank you, Erin, for your comment. Yes.
Thank you so much. I will now share my screen for our next presenter. And please communicate with Dr. Ugo in the chat if you would like her contact information. You are welcome to ask for it. Okay.
I'm going to place my contact information if anybody wants to learn more about it. Thank you so much.
Thank you for sharing that. Okay, so now I will be presenting Amy Yu. Amy Yu is a doctoral candidate at the University of Texas at Austin Steve Hicks School of Social Work. Prior to her doctoral studies, Amy obtained a Bachelor's of Arts from Simon Fraser University in Canada and a Master of Social Work from the University of Southern California with a concentration in community organizing, planning, and administration. Ms. Yu has a decade of experience supporting with individuals with intellectual and developmental disabilities of all ages and their families as a direct support professional, case manager, and a researcher. Her primary research interests are in family support, professional support, quality of life, and disparities in culturally diverse families of individuals with intellectual and developmental disabilities. Using socio-ecological frameworks and intersectional approaches, Ms. Yu's program of research focuses on 1, examining the caregiving experiences and quality of life outcomes among racially and ethnically diverse families of individuals with intellectual and developmental disabilities. 2, investigating the contextual factors that hinder or facilitate support provision, particularly as they age together. And 3, developing culturally relevant interventions that address health and social inequities. Ultimately, Ms. Yu aims to inform practices and policies that improve the sustainability of family caregiving in underserved groups. Ms. Yu was not able to be here live, but she has sent us a pre-recorded video that will have her contact information at the end. If you wish to contact her for questions or furthering information, she is open to that, and you will have the opportunity. I'll pause it at the very end so you guys can take screenshots or write it down, whatever works better for you. Give me one moment, please.
Everyone, my name is Amy Yu, and I'm a doctoral candidate at the University of Texas at Austin Stevig School of Social Work.
Does the sound a little off for you guys?
Yes, it is.
A little staticky.
Okay, give me a second.
from USC.
Interesting. When I stop sharing, it sounds fine.
Pronouns are she, her. The opportunity. Everyone, my name is Amy Yu, and I'm a doctoral candidate at the University.
Sorry for the technical difficulty. Ariana, do you mind?
Everyone, my name is Amy Yu, and I'm a doctoral candidate at the University of Texas at Austin Stevig School of Social Work, and also an MSW graduate from USC. My pronouns are she, her. Thank you for the opportunity to share about our work in this research symposium. My presentation today is titled Co-Creating a Culturally Tailored Intervention with Promotoras and Latina Caregivers of Children with Intellectual and Developmental Disabilities, a Conceptual Model. In this presentation, I will talk about our intervention project and how we've developed the curriculum with the community. I'll follow up with a model that we have developed over the course of the intervention that would really help inform future researchers in designing their own project with the community. Before I begin, I want to quickly give credit to Dr. Sandy Magania, who is leading the team in Texas, and Dr. Yolanda Suarez-Balcazar, who is our co-PI at University of Illinois, Chicago. So we really began this project wanting to address the issue of health disparities in children with intellectual and developmental disabilities and their caregivers. Research shows us that health of children with IDD fare far worse than their counterparts. They're prone to imbalanced diet, mental health, chronic health conditions, and lower levels of physical activities. And these are not only due to their disability-related conditions, but mainly due to systemic and resource barriers such as transportation, language barriers, financial barriers. They're prone to sedentary behaviors and increased risk of overweight, obesity, and other chronic health conditions, which of course that widens the gap of health disparities that already exist in racially and ethnically marginalized populations. Latinx children have been traditionally underdiagnosed, which then leads to a lack of preventive care and connection to services that also contributes to the health disparities that already exist. Similarly, with the health of caregivers of children with IDD, they fare far worse than health of caregivers of children without IDD. Latina caregivers of children with IDD have more likely to have other chronic health conditions and mental health conditions. And language barriers, financial burdens, discrimination, social isolations, and other additional systemic barriers adds to the risk of adverse health outcomes to these caregivers. And with that in mind, we wanted to come up with interventions programs that really address these issues. However, most evidence-based interventions are not tested with that culturally diverse populations. In fact, in the recent review of autism studies, out of more than 1,000 articles, only 25% report any data on race and ethnicity. So this is a daunting statistics that tells us that we really don't have a lot of programs that addresses culturally diverse populations and their needs. And that we know that they have unique needs that needs to be specifically addressed, and that to show effectiveness that they need to be culturally tailored. However, there are a lot of barriers to participating in these research or to have any access to research. This could include mistrusts with healthcare providers and researchers from previous experience, or multiple caregiving responsibilities, or issue of time or language issue. And these barriers could contribute to the reasons why the participation is low, or it could be a harder to reach population. And we really wanted to be able to design our intervention based on improving equity, meaning that we're not giving them the same bike and as shown in this figure, but the bikes or the tools or the accommodations that is based on their situation, based on their needs. And this is why we came up with Poder. Poder Familiar is the name of our intervention project. It is Spanish, meaning power of family. And in this intervention, really, we have two goals. And the goals are to promote the health and well-being of caregivers, as well as children with IDD and the whole family, and to maintain the healthy weight in Latinx children with IDD and their caregivers. It is this Poder Familiar is part of a 3 studies project that is funded by NYLR. And it is currently in the intervention phase. We've finished conducting our pilot study, and we're currently in our randomized control study right now. And what's special about Poder is that the key component to this project is that we have utilized the Promotora de Salud model. Utilizing the Promotora model, meaning that we are using promotoras as a means to deliver our interventions. Our promotoras in our study are not only from of the culture, but also should have that shared experience as mother of children with IDD. So they are better able to relate to our participants when they deliver the content, and better able to tailor the content according to the participants' families' needs, their child's needs, and their culture. And Poder Familiar is consisted of 10 remote sessions, one-on-one, delivered by the promotora or the parent leader, and 3 group sessions delivered by the staff. And now come on to the Dworak-Peck model. So we utilized this model as we were developing this intervention. And we've basically taken a lot of the previous knowledge and workshopped it and tailor it to specifically making this as our own. And so So the model illustrates 6 dimensions that facilitated the creation of the intervention in collaboration with the Latinx community. And these 6 dimensions include language and linguistic preferences, acculturation level, accessibility factors, reflecting values, ways of thinking, and ways of doing, dimensions of delivery and learning style, and social, cultural, and physical environment. At the core of this interactive dimensions are the voices of the community. And in our case, that includes the caregivers, promotoras, and the community partners. They provide extensive suggestions on ways to tailor the intervention curriculum to our target community. Throughout the project, we've elicited a lot of feedback on our curriculum and refining it for our RCT. And these include curriculum content such as using plain language, clarification, using cultural terms, and things like curriculum organization and format, making sure that we have more examples with more visuals. They're in bullet points, they're in short cases and stories that really help with the learning style. We've also added resources on mental health, and those are seeking mental health supports and examples on ways to manage stress and logistical issues. So we've paid attention to all these 6 elements and really refined it in the process of intervention development. That's on our left side. Moving on to the right side, we've also included implementation strategies that was grounded from our promotoras. They provided us with all these strategies that as they were delivering these interventions, they found these strategies to be very helpful in engaging our participants. And I didn't have time to go over our study's result in this presentation, but we did have a very good success with retaining our participants over our pilot study. And that is because a lot of it has to do with the rapport that they have built with the promotoras and their ways on tailoring the intervention that they found it to be helpful. And so here are the just elaboration of some of the things that we have done under each dimension that I will not go over here due to time, but you can just take out the examples that we have went through in these dimensions to really tailor our interventions according to our community's needs. So just to wrap up, this is a very extensive study, and I, of course, went by very quickly, but one of the key insights and strategies is the use of the Promotora de Salud model. It is very effective, and we have again shown to be effective that our participants have really engaged throughout the process, and that they have shown to improve in not only in their own well-being, but their child's well-being as well. We've centered promotoras and participants' voices throughout the design, development, and refinement of the intervention, which had really been the innovative piece in our approach, in that throughout the process, we've continuously engaged with the community and continuously wanting to refine this intervention to better suit their needs so that they would be able to go through the program and knowing that it is helpful for them and retaining the program content. We've not only done that because of this, we really exceeded that surface element of cultural adaptation by looking beyond language and linguistic preferences. We've also included the cultural values, ways of thinking and doing, and really using that strength-based approach, which is looking more emphasis on valuing the cultural assets of families rather than looking at their deficits. And last but not least is that the inbuilt flexibility in our framework and in the way that we've delivered the program. We've really given that flexibility for the promotores to be able to tailor the content in such ways that would be addressing the needs of the family, particularly in areas such as accessibility. Every child is different. They have different needs in terms of accessibility or the family's accessibility needs, depending on their physical environment. And so the promotor is able to discuss with the participants and brainstorm what are some of the strategies based on their these contextual settings that they're in. And so that's it. That's my very brief presentation on the model. But feel free to reach out to me for any questions, thoughts, or comments on this model or on Poder Familiar, our study in general. Here are some references to the articles. One is just recently published. It's about this model that I've just shared with you all. So if you want a deeper dive into understanding the model and how it works, please look up this article. And the second article is up and coming. It's currently in the revise and resubmit stage. It talks about this entire study, Poder Familiar, and how we have designed it, our methods, our results, and basically the whole entire study in a nutshell. So thank you all for listening, and I look forward to hearing from you. Thank you.
So there is her contact information. Thank you everybody again for bearing with us through the technical difficulties. If you have any questions, Amy was very eager to receive any information or comments. So please go ahead and reach out to her. She will be happy to hear from you all. And then I just want to say thank you to everyone who is still here. I know that we went past our time. We did have it open till 1, but we were trying to aim for 12:30, just because I know that a lot of people do have some other commitments, right, outside of here. But thank you all so much for participating, and I'll let Ariana close it out for us, and I will just share our last screen with you all.
All right. Thank you so much, Nydia. Thank you for joining us for a day of informative research and thoughtful discussion. If you'd like to connect with our board from Phi Alpha, please refer to our contact information. This includes our email and our social media, and then I've also included in our chat our LinkedIn and our recent March newsletter that highlights our upcoming events, such as our mental health awareness event that will be on May 1st. Thank you to our presenters for sharing your profound knowledge and for your contribution to enhancing learning. Thank you to our board members for your dedication to coordinating this research symposium, and to NASWCA for their additional support. And thank you all who attended. We sincerely appreciate your presence. And that concludes our research symposium for today.
Thank you.
Thank you.
Thank you all.
Thank you.